Please, can we see my screen?
No.
Okay. What about now?
Yes.
Okay. So, uh, I want to share some questions before we start, just like we normally do. See. Okay. So, can we see my screen now? Can we still see it?
Yes.
Okay, so let's just
Yes.
quickly go through them before we start. So, let's just take them one by one now. Oh yeah, who is starting? Dr. Miriam.
A 54, a 54-year-old woman comes to the physician because of multiple firm violations noticed on her right upper arm. She was diagnosed with right-sided breast carcinoma 12 years ago and was treated with radical mastectomy. Extensive axillary lymph node dissection performed at that time revealed no lymph node metastasis. Post-operatively, the patient developed chronic lymphedema involving her right arm. Which of the following is most likely a etiology of recurrent skin lesions? Uh,
Okay, it seems you have forgotten that part of dermatology. You know, chronic lymphedema in somebody, then after some time the person develops volaceous nodule. You know, and you are thinking it's a malignancy. So what malignancy is related to chronic lymphedema?
angiosarcoma.
Okay, Dr. Dr. Miriam, is that you?
Yes.
Yeah, so that's angiosarcoma. So we are going to talk more about it. So that's just a clean chart we need there. Just remember, chronic lymphedema,
Okay.
malignant transformation of the endothelial cells lining the vessels, particularly the lymphatics or the veins, any one of them. They undergo that malignant transformation, and it can bring about developing angiosarcoma. That's what we call the cervix Treves syndrome. So we'll talk about it when we get to angiosarcoma, all those proliferative lesions affecting the vessels. Okay. Uh, Dr. Antonia, is Dr. Antonia around? Okay.
That's false.
Okay, Dr. Antonia.
Okay. A 28-year-old man comes to the office with bilateral skin lesions over the posterior surface of the elbow. The lesions are itchy at times. Topical moisturizers have reduced the itching, but the lesions have remained. The patient has no chronic medical problems and takes no medications. Biopsy of the lesion demonstrate hyperkeratosis, parakeratosis, dilated capillaries in the dermal papilla, and foci of neutrophils in the superficial. Which of the following is most likely diagnosis? Okay. on the posterior surface, atopic dermatitis on the flexural surfaces, so it's not. Okay. Dermatitis herpetiformis comes with celiac disease, so there's no history of chronic medical problem in this patient. Erythema nodosum, I think is the answer.
Erythema nodosum. Erythema nodosum will not be correct because erythema nodosum typically occurs, number one, in the shin, in the
I said the answer is D.
Oh, I thought I heard.
My answer is
D, psoriasis. Okay.
No, it's D.
D, fine.
D as
so, the biopsy finding can help you. What biopsy usually says is diagnostic. So, from the biopsy, we can see evidence of, some changes within the epidermis, hyperkeratosis, thickening of the stratum corneum, parakeratosis, retention of the nuclei of those keratinocytes within the stratum corneum. Normally, when they get to the stratum corneum, which is the topmost layer, they should lose their nucleus. So now they are still retaining their nucleus. That is parakeratosis, and it's one of the cardinal signs of psoriasis. Although not only psoriasis can cause that, but most of the time, with respect to our USMLE, psoriasis will be, the answer most of the situation. Then the dilated capillaries. So this is what brings about the hospice side, which we are going to talk about. So, and we can see the distribution of the lesion. So they said the lesions are located within the posterior aspect of the elbow, even though they did not do very well to tell us the nature of this lesion, if they are plaques, if they are purple, because it's very important. So someone with psoriasis, it's more like a papillosquamous disease. So you expect the person to have plaques and purple in the posterior aspect of the body, like the elbow, like the knee. So coupled with the biopsy finding, we can confidently say that this is psoriasis. So we'll talk more about that when we get to psoriasis. Okay, Dr. Joy, is Dr. Joy there?
The following mechanism of action explains the antifungal activities of this drug. A 31-year-old man, a male farm worker comes to the physician complaining of an itchy rash on his chest. Physical examination reveals an annular and scaling plaque 5 centimeters in diameter with central clearing on the chest. KOH preparation of the skin scraping shows a branching septal hyphae, and a topical application of sildenafil was prescribed. Which of the following mechanism of action explains the antifungal activities of this drug? Sildenafil is they use it for dermatophytes, right? So usually they inhibit the fungal the spinal epioxidose, so it should be B.
Yeah.
But the case here is B, and the answer is B, but septal hyphae.
Yeah.
Septal hyphae looks more like Pardon?
Looks more like what? I'm listening.
Septal hyphae looks more like mucous guys will be non-septal, isn't it?
Yeah. So the stuff here is that yeah. So you might think this is aspergillosis, yeah. So but it's not only aspergillosis that have the septate hyphae. So that is why
we can't hear you properly.
Hello, can you hear me now? I can hear you clearly. Hello?
Yeah, if Dr. Virtue, the microphone is fine. Yeah, we can hear you now.
So it's not only aspergillus. So I think that was what you are trying to bring out from the branching septate hyphae. So it's not only aspergillus that brings about this picture.
I think aspergillus. Dr. Antonia said aspergillus.
Okay, yeah. So aspergillus will be a differential with respect to the KOH, evidence. So because you expect aspergillus to also show 45-degree branching, septate for that matter, hyphae. So, but dermatophytes too can show this kind of pattern. That's why, to be sure, you need to marry the symptoms together. So you are seeing more of skin lesions, and you are seeing some kind of scale itching, around that skin lesion. That's dermatophyte. So they are very pruritic. That's number one thing. And they have some, some kind of gross presentation, such as, you seeing circular rash with central clearing. So this is very specific for dermatophyte affecting the glabrous skin, the skin within the body. This is not even the one in the head. This is the body. This is tinea corporis. So once you see rash, erythematous rash with central clearing, and you did a KOH preparation of the skin scraping, and you are seeing the branching septate hyphae, that is dermatophyte. We cannot call this one aspergillus, because we know aspergillus typically affect maybe the lungs, goes to the bone, the eyes. It doesn't typically. Maybe it can cause skin lesion, but it's not classic like you seeing central clearing. So that has narrowed it down for you, as well as the history of the itchiness. Yeah, and exactly. So if we are working with aspergillus now, we'll not have considered terbinafine. We'll have considered something stronger, So
of course.
yeah, all right. So I know you guys remember the other ones. So binding to ergosterol is very specific for nystatin. No, binding.
Hepatitis B and nystatin.
Yeah.
So if it's binding, you are binding and making whole. That's amphotericin B and nystatin. So if it's inhibiting the synthesis of ergosterol, so that's where the azoles come in. So blocking of the beta D glucan. So which one is this?
Just like the steroid synthesis.
Yeah, so the echinocandins.
Yeah,
Like caspofungin, and the like. So preventing mitosis by binding tubulin. So which one is exactly? So this is grisoflovin. But we know that we can also use grisoflovin for what? For what condition? Do we remember? Dermatophytes.
Yeah.
Just like terbinafine, both of them, they are for dermatophyte. Then inhibition of fungal protein synthesis. Okay, so exactly. So that's the idea. Inhibit DNA, and so that means there's no way you can form protein. So that's very correct. Very correct. Good job. Okay. Who wants to take this? Please, let another person take this. I don't want to.
Let me try.
Okay.
Who wants to try? Dr. Antonia, you have. Is there any other person that wants to try before Dr. Antonia that have not taken?
Okay, Dr. Washington.
Oh, Dr. Alada, do you want to try, or Dr. Antonia should take it?
Yes,
Do you want to try?
she can take it.
Okay.
She can take it, yeah.
Okay.
28-year-old woman is brought to the emergency department by her family due to acute left ankle pain. The pain radiates to her groin and is associated with pinch hematuria and urinary urgency. Past medical history is unremarkable, and the patient has never experienced similar symptoms. CT scan of the urinary system confirms the presence of a stone at the ureterovesical junction. The patient is given intravenous morphine sulfate for pain. 15 minutes later, she develops diffuse itching involving the arm, the legs, and the back. Which of the following is the most likely mechanism causing this patient's adverse reaction? This is IgE dependent mast cell.
So
This
This is a very straightforward answer.
very straightforward.
it's just straightforward.
It's very straightforward.
Yeah. Well, me, I can't even tell.
What is that medication?
Other meds, well, other meds that can cause it is vancomycin,
What
the
for
red
my
one.
yeah. At
We also
said
have
what else?
contrast,
Yeah.
iodine
Contrast,
contrast,
yeah.
iodine contrast.
So
Yeah,
we
there are
well
three of them.
maybe here it's the opioid, the morphine. It's possible that it's the morphine. So because
Yes, it's morphine.
after they
And I
give
think methadone is all.
Anything morphine,
Anything opioid.
vancomycin, yeah, opioid, anything opioid,
Opioid.
vancomycins and contrast.
yeah.
The three of them.
So this guy,
Master
it's possible that this guy has also taken contrast. He's doing a CT. So contrast with the morphine
Yes,
further exacerbated the whole stuff, and
yes.
the patient came down with the IG independent. So all those ones you don't need the IG to cross link before the mast cells can degranulate. So they occur even independent of the IgA action on the mast cells. So that's very, very important. Those three things: vancomycin, the opioid, and the radio contrast. Okay. Okay. So I think Dr. Miriam is the next now. Dr. Miriam.
A 64-year-old man comes to the office with a full history of severe left-sided chest discomfort. The pain is constant and has a burning quality. Over the last day, the patient has developed a rash in the area of discomfort. He has not had similar symptoms before. Past medical history is unremarkable. The patient is a fever and vital signs are normal. Physical examination shows a vascular rash at the fifth left intercostal space. Which of the following pathologic findings is most likely to be found in the affected area? This should be shingles, right?
Mm-hmm.
So that should be multinucleated cells with intranuclear inclusions.
Yeah. So what do you think option C is talking about?
HPV.
HPV.
That's the HPV
Okay.
virus.
So talk about the other ones, because I don't know if we'll be able to remember the other. Which one is option A?
That's staph toxin.
Is this staph?
Toxin, yeah. I can call
IgG.
it.
No, I was
IgG.
thinking
IgG.
Yeah,
IgG.
IgG deposits, intracellular IgG deposits are acantholysis.
So that means it's an
Doesn't
autoimmune.
have antibody to the
So that's pemphigoid. That's pemphigoid vulgaris.
Oh,
So
Yes, yeah.
that's pemphigoid. Okay. So let's just quickly see. So going through the dermatology all over again. Starting from the skin layers, we know 3 essential layers. So the epidermis, the dermis, the subcutaneous tissue. So the epidermis has 5 layers. So 5 layers of cells. The stratum corneum is the outermost one. We have the stratum lucidium, which is next. We can see the image. So the granulosome, the spinosome, the basale. So all of them are important, especially the corneum, the granulosome, the spinosome, and the basale, because we'll talk about so many pathologies that are affecting these areas. So, but before we leave, I just want us to know that the stratum lucidium is particularly present in where we have thick skin, like the palm and the sole. That's number 1 point. Number 2 point is within these layers, we have so many cells that are interspersed there. 90% of the cells within the epidermis are made up of the keratinocytes. So keratinocytes are like the most, popular cells within the epidermis. Then within the epidermis, we also have some other cells like the Langerhans cells that helps to present antigen, to the lymph nodes. We have the melanocytes, but you find most of the melanocytes in the dermis. But you remember that the melanocytes are the one that helps us secrete melanin, but the melanin must be transmitted to the keratinocytes so that they can show the color, the black color. They can impact the black color to the skin. So the melanocytes within the dermis have to produce melanin that is transported to the keratinocyte. And we should not forget that the keratinocyte basically synthesizes keratin which is a cytoskeleton that supports the skin. So it maintains the integrity and offers it, some kind of rigid support so that it doesn't just be fragile and just be breaking off. Keratin, very important. So within the dermis, we have the melanocyte, we have the sebaceous gland that secretes sebum, which keeps our skin supple and fresh. We also have the hair follicle emerging from the dermis upwards, from through the epidermis to the outer part of the skin. Then the area that is just beneath the dermis is our subcutaneous tissue. So that's the one that allows for, insulation and the likes. So we have the epithelial cell junction, which are like connections within the epithelial cells in the skin that helps to hold them together. So we have about 5 of them.
Yeah. You said which one helps to support for
Insulation. The subcute.
Subcute. Okay, the subcute.
Yeah.
And the sebaceous glands and the hair follicles comes from
the dermis, right? The dermis.
Okay.
So the junctions, we have 5 of them: the tight, the adherens, desmosal, gap, and hemidesmosal. So I just want us to focus more on the desmosal and the hemidesmosal. Those ones are the ones that are clinically relevant. But it's good to know everything because you never can tell. So the tight junction, we can see the picture, we can see, what it looks like. All of them usually have like a protein that mediates the interaction, the connection. There's always a protein. For example, for tight junction, the proteins that are involved there are what we call the claudins and the occludins. So all this blue stuff that we are seeing, they can either be claudin or occludin. So they help us occlude the epithelial cells together. And why are they doing that? They are doing that to prevent paracellular movement of solute and water from escaping from the skin. So solute, water don't pass from the blood through the skin to the atmosphere. So anything within the skin will be kept within the skin. They will not move through the paracellular pathway. That's the function of the tight junction. Then we also have the adherens junction. The adherens junction is quite different from the tight junction because its own protein is not claudin or occludin. Its own protein is what we call the cadherin. So you can see it here, CADEHERIN here, the cadherins. So they are called the calcium dependent adherent addition proteins. So we can see a picture of a cadherin here. It is not only adherens junction that is using cadherin. The desmosomes also use it. But let's still focus on the adherens junction for now. So what is it doing? So from the word cadherin, so connect, C for connect, A for actin filament together. That's what it does. So because we have not only keratin within the skin, we also have actin cytoskeleton. All of them work together to maintain, to allow for support, for structural integrity. The actin cytoskeleton, the keratin. We remember, maybe I can't remember the part where we did it, but there's a part in our first day that talks about, some of those filaments. I think maybe in biochemistry or something. The intermediate filament. Do we remember? There's a part that it talks about.
Yeah.
But I can't remember. Biochemistry. So they talk about the intermediate filament like keratin, vermectin, and the likes. So actin is also like a cytoskeleton. It's like a filament, but it's not part of the intermediate filament. It's on its own. So actin cytoskeleton, they are also for structural, support, and they are being held together. So you hold 2 actin cytoskeleton together with the head of the cadherin within an adherens junction. So all of them like that, the actin cytoskeleton and the cadherin makes up the adherens junction. So an example of a cadherin is the E cadherin. And remember when we were talking about metastasis in pathology, we said the E cadherin kind of holds the cell together in contact so that they don't proliferate abnormally. So contact inhibition. So because it's a form of cell junction. So if you have a compromise of the action of the cadherin and you can't maintain contact between the cells together, you have loss of that contact inhibition, and you can have abnormal proliferation and metastasis of that cell. So cadherin, in that regard, we should remember. Then desmosome. So these ones are
Sorry,
very
Dr.
important.
Bawale.
Yeah, I'm listening.
Sorry, Dr. Bawale. Are you recording, please?
Yes, I am.
Okay.
Yes, I am.
Okay, boss, we need it. We need it for that.
Okay, so desmosomes. So desmosome. So one thing about the desmosome and hemidesmosome that I want us to remember is that whenever we come across the word hemidesmosome or desmosome, any smosome stuff, we know that the intermediate filament will be involved. That's what we should have at the back of our mind. For adherence junction, it is actin cytoskeleton, but for the desmosomes, hemi or desmosome, it will be intermediate filament. And which intermediate filament are we talking about? Keratin. So desmosome is a junction which we can see in image C, that is holding two intermediate filaments together within the skin. So keratin of one epithelial cell to keratin of another cell. So what is now the protein that is connecting them? Desmoglein. And desmoglein is a form of what's it called? Adherence protein. So it's a, we said we have adherence protein, and they mediate connection within the adherence junction and the desmosome. And I also went ahead to give example of the adherence protein for adherence junction to be cadherin. So the adherence protein now for desmosome is what we call the desmoglein. So desmoglein 1, desmoglein 3, they are very, very important. So the desmosome is just a connection between two intermediate filaments, the keratin and another keratin, joined together by the desmoglein 1 or 3. So it's important because you can have antibodies against that desmoglein protein, and when there's antibody against the desmoglein, it destroys the desmoglein and the integrity of that interaction breaks off. So you can have easy splitting of the skin. You can easily separate the skin's layers, because of that lack of interaction. So that is what is responsible for the pathophysiology of the staphylococcal scarlet skin syndrome, because of damage to the desmoglein, as well as pemphigoid vulgaris. So both of them have compromise of the desmoglein. It's just that what is mediating one differs from the other. For the staphylococcus, it's due to the exfoliative toxin A, that toxin A. Why for pemphigoid, it's due to antibody, not the toxin now. It's an autoimmune disease, so you are producing IgG against that desmoglein. So we can see here autoantibodies in desmoglein for pemphigoid vulgaris. Then next we have the gap junction. So gap junction is very straightforward, just like anywhere else in the brain, in the heart. The gap junctions are just there to allow easy transmission of electrical impulse, chemicals, usually to allow for cellular growth and differentiation. That's just a gap junction. The protein that do that is what we call the connexin. That is that. Then lastly, we have the hemidesmosome. So just like I've mentioned, when we come across the word desmosome, we should know that intermediate filament must be involved. So here, intermediate filament is involved, but this is hemi. It means that it is not joining two intermediate filaments together. It's joining one intermediate filament within the epithelial surface to another structure within the basement membrane, because the hemidesmosome is the one that is, the one beneath. It joins the intermediate filament within the epithelial cells, which is this structure we are seeing here, which is the keratin, to the basement membrane that separates it from the dermis. So there's a basement membrane here that separates from the dermis. So what is mediating that interaction is the hemidesmosome. But what protein is it using? So that is what the next question to now ask ourselves. What protein is it using? So Just like desmosome that is using desmoglein, it is not using desmoglein. It is using integrin. Integrin. So integrin is the one that is maintaining the integrity of the basolateral membrane. So it connects the keratin to the basal membrane, but it doesn't attach it to the basal membrane directly. It needs some factors to bind to in the basal membrane, and that's where collagen, laminin, fibronectin comes in. So these ones are very, abundant component of the extracellular matrix within the basal membrane. So collagen is there, laminin is so much, fibronectin are there. So what your integrin is just doing is that it's just connecting the intermediate filament, which is the keratin of the epithelial cell, to the laminin, the fibronectin, and the collagen of the basal membrane, just like we can see in this picture. So those are the epithelial connections. Very important, we must remember the desmosome as the one that is beneath within the basal membrane, and the desmosome, which is the one within the epithelial cells, connecting to keratin to another. So moving on to the exocrine glands. So exocrine glands are glands that produce their secretion into an epithelial surface. So we've been talking about epithelial stuff since morning, so that means we have to complete it, because we need to talk about the appendages like the exocrine gland. So they are very much different from the endocrine glands, because you have the endocrine glands secreting their own secretion directly into the bloodstream and not within the epithelial surface, and again it passes through ducts. So their own doesn't pass through duct, it's ductless, so they just secrete directly to the bloodstream. But the exocrine gland, they secrete into epithelial surface through duct, so they use duct, exocrine, duct. So based on the pattern of that ductal secretion, we can now classify them into three. So what I want us to get it clearly. Based on the pattern of the secretion, that is how they are able to achieve their secretion, is the basis for the classification into three forms. So the merocrine approach, the apocrine approach, and the holocrine approach. These things are very easy to forget, but the way I feel we can retain the knowledge is just by putting some codes into the nomenclature. So let me start with holocrine. Holo. So holo, oil. So oil, I think I have the stuff here. Holocrine, oil. So that means that it is one that the sebaceous gland uses. We know that sebaceous gland secretes sebum, and we know that sebum is oily. So holocrine will be for sebaceous gland, oily glands. But what is the approach for holocrine? You have to destroy that cell. That is it. So it's like you squeeze something. When you squeeze something, you don't destroy them. So they will squeeze and destroy that cell and empty its contents into whatever place they want to secrete it within the skin. So that is the holocrine approach. You disintegrate and destroy that cell. The apocrine. So apocrine is just like making a pinch. You pinch something out. You form a bud. So if you look at the word apocrine, you can pick the word apical from that. Apical. And let us look at the nipple of the breast. The nipple of the breast is kind of pointed. It's more like an apical structure. So apocrine is for the mammary glands, like the breast. So how they secrete their milk, they have to pinch out all the vesicles that contain that milk. They will pinch them out and they will be released like that. So the portion of the cell that contains that secretion is kind of pinched out. That is it. That is the apocrine approach. Why the last one is the merocrine. So merocrine, I changed that one to mexocrine. So mero. It means that they follow the exocrine approach. So the secretion leaves the cell by exocytosis. So that is it. It just diffuses out of the cell without needing to be pinched out, or without you needing to squeeze or destroy the cell. You just need to bring it out by exocytosis. It's very straightforward. And this one is very common for all those ones that have so many things that they want to secrete, like saliva, like sweat. Sweat is abundant, saliva is abundant. So they go through the exocrine approach, which is a merocrine secretion. So holocrine, oil, sebaceous gland. Apocrine, apical structure, the breast, mammary gland. Then the merocrine, exocytosis, abundant stuff like saliva and sweat. So, by the time we, try to familiarize ourselves with these things, it's definitely going to stay. So that's that about the glands. So, moving on to the dermatologic macroscopic terms. So, you look at a lesion, you are able to assign a name to it based on its size and its shape, as well as its if it's elevated or not. So the first one is what we call the macule. Macules are flat lesions that are less than 1 cm. So you see a lesion flat, the same level as the neighboring skin cell, and it is less than 1 cm. You call that a macule. We can see picture here showing a labial macule. So frequent sun exposure can cause this. Just see this hyperpigmentation on the lips, labial macule. So you can see that the lesion is flat and is less than 1 cm. So what if this lesion is flat and it is more than 1 cm? So the name will now change to a patch, which you can see in image B. So you can see that this one is also flat, a flat hypopigmentation that is more than 1 cm. So this is a patch, very typical for vitiligo, very fantastic for vitiligo, patches everywhere. Then what if this lesion is okay, so let me so that I don't cause confusion, let's just move according to the way it was arranged. So for the purple, so now the lesion is no longer flat now, but it's elevated, it's raised, but it is less than 1 cm. So if the lesion is raised and less than 1 cm, that is a purple, just like we have in image C, which is showing neurofibromas. You can see so many lesions. Although this is like a mixture, it's not everything that is purple. Yeah, some of them are actually more than 1 cm. So we can say we have blacks and we have purple, but we should just focus on the tiny ones that are elevated. Those are the purple because they are raised and they are less than 1 cm. So what if they are greater than 1 cm? So that it changes to a plaque. So plaque is bigger than a purple. So it's more like a purple that is more than 1 cm. That's a plaque. So you see so many plaques in all these papulosquamous disease like psoriasis, lichen planus. So you can see image D showing this raised lesion that is more than 1 cm. So this psoriasis, it's a plaque. Then we also have raised lesion less than 1 cm, but because if it's raised and less than 1 cm, that automatically makes it a purple. But if it contains fluid, then it changes to a vesicle. So raised less than 1 cm, but it contains fluid, that's a vesicle. And we know vesicles are very common to some pathologies like chickenpox, like shingles, like someone that has this hand, foot and mouth disease. They have vesicles all over their body, fluid containing blisters. What if we have the lesion containing fluid raised more than 1 cm? So it's no longer a vesicle but a bullae. So many bullous lesion, for example, bullous pemphigoid. So a bullae, necrotizing fasciitis, you can see bullae. You can see bullous lesion there, more than 1 cm containing fluid. Then the pustules. So pustules are just like purple that contains pus, or vesicles that contains pus. That is pustule. So for example, pustular psoriasis, chickenpox, you can have pustules. Then wheal is just more like a transient lesion, a transient plaque or a transient purple that appears then disappears after some few minutes to hours. That's a wheal. We typically see it in people that have urticaria. They have so many wheals, because urticaria it's more like an allergic response, type 1 hypersensitivity that appears and disappears after some time. Then scaling is just talking about flaking off of the stratum corneum, because you tend to have constant shedding off of the cells, the corneocytes within the stratum corneum. The keratinocyte, they will flake off and disappear. But sometimes you don't have all those desquamation happening completely. You have some of them staying. They are not completely desquamated. They will still be retained within the skin. And that kind of situation, you see them appearing like scale. So you have so many diseases that is characterized by scaling. Like depending on the color, someone that has psoriasis now, you see silvery scale. So someone that has actinic keratosis or the squamous cell cancer, you see white scale. So people that have the dermatophytic infections too, you see scales. So many things that might be associated with scaling. That's just due to flaking of the stratum corneum. Crust. So crust is just when you have a lesion that contains fluid. The lesion breaks open, the fluid leaks out and gets dried on the surface. That's like a purulent exudate leaving a lesion and dries on the surface. They form crust. So impetigo is a very good example of such disease pathology. Crusting can be seen in impetigo. So you can see this yellow crust in impetigo. Yellow crust in impetigo. You can also see yellow crusting in somebody that has seborrheic dermatitis. So of course you expect impetigo in a child, just like we have in this young guy that is here. You can see the yellowish exudate, the crusting in the cheeks. So this is very classic for impetigo. We will not be expecting a child to have seborrheic dermatitis in the cheeks. I mean, if a child is going to have seborrheic dermatitis, you typically see it more in the head, which you call the cradle cap. So that's that about cross. You can also see cross in people with chicken pox. So that will be the end result of the lesions. So as they move from the vesicles to the pustules to the, some of them can form vesicles, they can form pustules, papules. Then later they will get crusted, and you see these lesions, these crusted lesions with the skin. So that means they have completed their evolutionary stage. So it's very important for us to remember those nomenclature. Then those are the macroscopic terms. So what about the ones that we see on the microscope? So for the first one, dyskeratosis. So dyskeratosis is just talking about abnormal premature keratinization. So this keratinization process starts from the stratum basale. As the cells, the keratinocytes, because most of them are produced from the stratum basale, then they ascend up to the stratum corneum, they get shed off and they disappear. They are replaced by new ones. So as they migrate, they start synthesizing keratin, and the process gets completed by the time they are approaching the stratum corneum. But in this keratosis, you have premature keratinization, in which most of those cells have had their keratin even before they pass beyond the stratum granulosum. Within the stratum basale, the stratum spinosum, they already have the keratin. It means that there's an uncontrolled proliferation happening within the keratinocyte. So that is, why it's peculiar to squamous cell cancer, because people with cutaneous squamous cell carcinoma, they have abnormal proliferation of the keratinocyte. That is it. So they have this keratosis as a feature. So if you see in the question stem, what you think about squamous cell cancer, hyperkeratosis. You can see so many diseases showing hyperkeratosis, but what do they mean? So hyperkeratosis just means increased thickness of the stratum corneum. The stratum corneum, which is the most superficial layer, has increased in size. So many things can cause that. Psoriasis is one of them. Lichen planus is another. So all those papillosquamous disorder, psoriasis, lichen planus, someone that even have what, can have hyperkeratosis. So it's not something I want us to cram or learn, because it's not specific for any lesion. You can have it in so many lesions, psoriasis, lichen planus, what, so many lesions. But it's good to understand what it means, which is what increased thickness of the stratum corneum. Parakeratosis. As the keratinocyte gets to the stratum corneum, they flatten out and what? They lose their nuclei. That is it. So, but in parakeratosis, you don't have that loss of nuclei. So they still retain their nuclei. So it gives them this So any keratinocyte that we see in the microscope that still have its nucleus being retained at the level of the stratum corneum, we call that parakeratotic feature. It's very, very specific for psoriasis. Although you can also see it in someone that has actinic keratosis, which we are going to talk about. But let's just put it at the back of our mind that psoriasis is the most common cause of parakeratosis, psoriasis. Hypergranulosis is very specific for lichen planus. So in hypergranulosis, we are not having thickening of the corneum now, but thickening of the granulosum layer. Granulosis. So it's very typical for lichen planus. Spongiosis is when you have fluid within the epidermis. So the epidermal layer, you have fluid accumulating within them. So this is a feature of early phase of eczematous dermatitis, atopic dermatitis. In the early phase, you tend to have this dermatal fluid accumulating within the epidermal layer. So you call that spongiosis. So once you see them describing on biopsy, spongiosis, you want to consider atopic dermatitis or eczematous dermatitis. Acantholysis is when you have separation of those epidermal cells, meaning there's a compromise of the cell junction that is attaching them together. So you can now separate those epidermal cells. So that is acantholysis. So you can get that from pemphigus vulgaris too. Acanthosis. So we should not mix it up. Acanthosis is quite different from acantholysis. Lysis is separation. Lysis. But in acanthosis, you have increased thickness of the epidermis, particularly at the stratum spinosum layer. So you can see it in someone that has acanthosis nigricans from the name. Acanthosis nigricans. So there's acanthosis. And also in psoriasis. So psoriasis, you see hyperkeratosis, you see parakeratosis, you see acanthosis. So acanthosis, thickness within the stratum spinosum due to increase in the number of cells within that area. Parakeratosis, retention of the nuclei within the stratum corneum. Then hyperkeratosis, thickness of the stratum corneum. We should not forget that. So,
Dr. Babawa, in parakeratosis, do you also see it in lichen planus?
the what? The which one? Dr. Antonia? Hello, can anybody hear me?
Okay. No, we can't hear you.
Can you hear me now?
Yeah.
I said, like, in parakeratosis, do you also have parakeratosis in lichen planus?
No. So parakeratosis is specific for psoriasis. In lichen planus, it's only two things: hyperkeratosis, hypergranulosis. In fact, they will tell you that acanthosis is not there. So, reduction in the thickness of the spinosum, increase in the thickness of the granulosum. Very specific for lichen planus. So,
Dr. Bowale, when you mentioned you said that the parakeratosis loses their nuclei. Then you mentioned that the hyperkeratosis they lose their nuclei, then the para retains it. Is that correct?
yes, para means retention. You see, ideally, the cells, once they get to the stratum corneum, they should lose it.
Okay.
So in
What about
parakeratosis,
the hyperkeratosis?
hyperkeratosis is just talking about the thickness of the stratum corneum. How thick is it? If it's very thick, more than normal, that is hyperkeratosis. Do you get the
I
difference
was
now?
trying to figure out. I get the difference, but I know you mentioned something about one retaining their nuclei and the other one losing their nuclei. That's the one I was trying to look for. The one you said that loses nuclei. That's what I was saying.
Yeah, so losing nuclei is not a pathology. It's a normal thing that should happen. So once the keratinocyte gets to the stratum corneum, they should lose their nuclei. But if there is retention of that nuclei by the keratinocyte in the stratum corneum, that is parakeratosis. So
All right, thank you.
you are considering psoriasis. So the pigmented skin disorder is associated with problems with pigmentation, either hyperpigmentation or hypopigmentation. So majority of the ones we'll be talking about will be hypopigmentation. So we can see this first picture. We can see this lady, looking white. So This is albinism. And what is the problem of albinism? There is more like a diffuse hypopigmentation. Why? Because melanin is not there. Because melanin is the one that is transmitted by the melanocyte to the keratinocyte so that we can impart a dark color to the skin. So you can say that we blacks, we have a lot of melanin in us. So in albinos, they have problem with that melanin production, either due to compromise of the thyroxinase activity. Thyroxinase is an enzyme that converts thyroxine to melanin. So either that enzyme is deficient, in them, autosomal recessive, condition in which you have absence of that enzyme, or there's a problem with the thyroxine transport. So you need a protein that helps us to deliver the thyroxine. But if there's a problem with the protein that helps to deliver the thyroxine will not be available, and there's no way melanin will be produced. So they can develop albinism. So this is usually a genetic problem, and it confers a very high risk of developing squamous cell cancer of the skin. So most of the time, it will be linked to thyroxinase deficiency. So we should not forget that the melanocyte number in them is normal. It's just that the melanin production by this melanocyte is reduced or absent. The next one is melasma or chloasma. So this is when you have hyperpigmentation of the skin. So it's very, very common in people that have high oestrogenic state. So people using OCPs or people that are pregnant. So it has a stimulatory effect on the melanocytes, making them secrete more melanin, which impacts hyperpigmented lesions on the skin. Just like you can see in the face of this woman, this black spot in this face. That's melasma, hyperpigmentation. Vitiligo. So vitiligo, most of the time, to make diagnosis of vitiligo, we are going to be seeing patches of deep pigmentation of the skin.
So sorry, Dr. Babawale. So with estrogen effect, it causes an increase in the melanocytes or their secretory ability. Which one? Is it increase in the number of melanocytes?
No, it's not increase. It just stimulates them to secrete more melanin. So
okay, more secretory effect.
More secretory effect. So that's that about melasma. Vitiligo. So you have a patchy, irregular depigmentation of the skin. So it's not as diffuse as albinism. Just have it in some part of the body, like maybe the legs, the hands. So the hands, so that's what we call the acral vitiligo. You have so many subtypes, but we should remember that it's patchy. It's not total depigmentation vitiligo. And most importantly, we are going to get history of autoimmune disease, because the pathophysiology of vitiligo is when you have autoimmune destruction of the melanocytes. So here, the melanocytes are actually being destroyed by the autoimmune condition. So you have antibodies that are destroying those melanocytes. So that's why vitiligo is associated with other autoimmune disorders. So you can see that they paint picture of someone that has pernicious anemia, somebody with type 1 diabetes, any other autoimmune disease, autoimmune thyroiditis, anyone with vitiligo. You can be rest assured that what you are picking should be vitiligo. You can even see it vice versa. For example, you can be in the hematology section now, and are trying to paint a picture of someone with megaloblastic anemia, and you get a history of somebody of the fact that the person has vitiligo. You definitely know that for the cause of that megaloblastic anemia, you will not go and pick vitamin B12 deficiency from diet. No, it's going to be from absorption in the stomach. That is it. So due to pernicious anemia, so they go hand in hand. So you always see them working together with other autoimmune conditions. So vitiligo, look out for other autoimmune conditions: autoimmune thyroiditis, pernicious anemia, what's it called, type 1 DM, and the likes. And the problem is destruction of melanocytes by those antibodies. So Waardenburg syndrome. We are still going to get history of depigmentation, which is patchy, particularly affecting the hair, causing what we call poliosis. So let me show us an image of what we are going to expect. Poliosis. So I think I have an image here. Okay, so you can see this. So this is it. So we are going to have patchy depigmentation of the anterior aspect of the forehead, this part. So this is what we call poliosis. And in addition to that, the patient is going to have some other problems. For example, the patient is going to experience sensorineural deafness, depigmentation of the eyes. So because you need those melanin pigment to impart color of the eyes. So the eyes will lack the pigment and it will appear blue. You can see this person's eye is looking bluish. You can see the forelock, this poliosis in the head. And we can see that there's like a dysmorphic appearance of this face. It's not looking normal. Yeah, because you remember that the problem in Waardenburg syndrome is, differentiation of the neural crest cells, into their derivative. For example, the melanocytes. So the neural crest cells give rise to the melanocytes. They give rise to the inner bone of the hair. They give rise to the bone and the cartilage of the face. You can see that it means that because of that failure of differentiation to the cartilage and the bone of the face, that's why this face is looking somehow. And because of failure of differentiation to the melanocyte, you can see that in some part of the body, because we can see that this hair is appearing depigmented and the eyes too is looking bluish. Then the person is also going to experience sensorineural deafness. So once you're able to get all those history together, we know what you are working with is not vitiligo, but Waardenburg syndrome. So very important to remember that. So I think we don't have any image for Waardenburg here. So moving on to the next one, which is seborrheic dermatitis. So seborrheic dermatitis is more like a skin lesion which appears erythematous. That's the first thing. So we see erythematous plaque. So this image is not very clear, but if we look down to the chin, we see this reddish, lesions here. This reddish lesion somewhere here, somewhere here, somewhere here. So erythematous plaque with greasy yellow scales. So once you see that, we know we are working with seborrheic dermatitis. You tend to see it in areas of the body where you have high secretion of sebum, like the face, the scalp, the upper chest. So, erythematous, well demarcated plaques with greasy. That greasy part is already telling us this is likely to be sebum. Yellowish scales in the areas rich in sebaceous gland, the face, the scalp. That is seborrheic dermatitis. Very common in adults, particularly adults which are immunosuppressed or adults with Parkinson's disease. So those are the things to look out for. Immunosuppressed or Parkinson's disease, seborrheic dermatitis. But if it's a case of an infant, they are not going to have their own in the face here. It typically occurs in the scalp, and that's what we call the cradle cap. So let me show us what the cradle caps looks like. So we can see the yellowish scaling, erythematous. We can see the erythematous black background, and we can see the yellowish scale in the head. So this is cradle cap. So this is no cause for alarm. Well, this is not step 2, so we should not go to treatment. This is just what it looks like. So this is seborrheic dermatitis in a child. So the implicating organism is the Malassezia. So the Malassezia globosa or the 4 those are the ones that are responsible for this. So you want to give antifungal, to treat it. You want to give antifungal agent to treat, the condition. So that's it. So you just give topical antifungal or glucocorticoid to reduce, the condition. So Malassezia, we should not forget, Malassezia is implicated. It's very common in adults with Parkinson's disease, seborrheic dermatitis. So the other ones include acne. So acne is commonly tested. We need to know how it looks like. We just see erythematous, purple, pustules. Sometimes it can be very severe that the person will have nodules, cysts that will be discharging, in acne. So, but we need to most importantly understand the etiology. How does it happen? So the etiology is multifactorial. So the first thing to understand is that people with acne, they have abnormal keratinocyte desquamation. So keratinocytes that they are due, they are dead, they need to go off. They don't go off, they stay. And the keratin component within those keratinocytes, they tend to occlude the follicle. So there's something we call the pilosebaceous unit. So the pilosebaceous unit is just talking about the sebum in the dermis and the hair follicle that is surrounding. So the sebum surround the hair follicle, it secretes into the follicle. So in people with acne, because of this abnormal keratinocyte desquamation, which we can see here that I'm highlighting, you have keratin occluding the follicle. That's the beginning of the problem. Keratin occlude the follicle. In addition to this, you can have increased size of the sebaceous gland, either due to puberty, because when a child reaches puberty, you have increased secretion of androgens. So the androgens stimulate the sebaceous gland, they become big and they start secreting sebum, and that sebum can also occlude the hair follicle. And when it occludes the hair follicle, the next thing that will happen is that Cutibacterium acnes is like a bacteria that feeds on sebum. So it's going to start feeding on the sebum, breaking it down, and colonize the pilosebaceous unit, which is the hair follicle and the sebaceous gland. And in the process, the breakdown product of that sebum can trigger inflammation. So that brings about follicular inflammation, which leads to generation of the lesion, which can appear as the papules, the pustule, the nodes, or the cysts. So everything works together. So the first thing is you have abnormal keratinocyte desquamation, in which you have follicular plugging by keratin. And if the child is of pubertal age, elaboration of androgen stimulating the sebaceous gland, they produce more sebum. The sebum also occludes the follicle. Then the bacteria comes in, the Cutibacterium acnes, and they start breaking out that sebum, and the breakdown product triggers the inflammation, which brings about the lesion. So that means that if we want to treat acne, it makes sense for us to tackle any form of this etiology. Any one of this process can be altered. So for example, if we want to kill off the bacteria, we can give some antibiotics. So we can give doxycycline, we can give erythromycin. If we want to inhibit the follicular plugging, we can give some agents like benzoyl peroxide. So the benzoyl peroxide kills the bacteria, and at the same time it also opens the pores of the follicles, relieves the keratin obstruction. Then retinoids also stabilize the follicle and prevent them from being occluded by the keratin. So that's the pathophysiology. That's how this, not the pathophysiology now, but the mechanism of action of all these agents. So antibiotics, benzoyl peroxide, and retinoids like isotretinoin. It's a retinoid that we use to treat acne. Benzoyl peroxide is the first line. Then we can use some antibiotics. We should not forget, people with acne, they have what we call comedones. So comedones usually come up when you have occlusion of the follicles, and you have two types: the open and the closed comedones. The open, the closed. So the way I learn it is just by remembering WC, water closet, WC. So WC. So the white comedones, the white head comedones, those ones are the closed one, WC. So white are closed, the black are open, and it makes sense. If the black are open, it means that the follicles are occluded, but they are still open, and they can be easily oxidized. So the oxidation of those follicular content is what makes them black. But for the closed one, there's no way the oxidizing agent can get into, they won't be oxidized, so they appear white. So let's look at what it looks like, so that we'll be able to appreciate all these things by the time we see them in questions. So acne, I think I have a picture of the acne, and we can see these ladies.
Sorry, Dr. Babawale.
Yes.
Yes, so are you saying that the comedones in acne are white type and white type?
So they can be white or black. We have the black comedones, we have the white comedone. The white comedones are closed, WC. The black comedones are open. They are open, making them oxidized, making them look black. So here I think we can only see like two white comedones here. One here, one here, one here. We can't see any black stuff here. Not very evident, but we can see the black ones here, here, here. Hope you can see my cursor. Can we see my cursor?
Yes, we can.
So somebody having this stuff now, these are black comedone. You know that this is acne. Why the white ones are the white comedone. So the presence of the comedone is very typical for acne. So
Sorry, Dr. Babawale, can you just shed more light on the difference between the white and the black?
So what I just want us to take home is that the white comedones are open, they are closed. The white comedone are closed, WC, they are closed lesion. The black ones, they are open, and they are black.
Yeah, we get that.
Okay, so what else do you want to know?
No, the fact, when you were talking about the fact why they are black and what happened, what is really involved, that's what I got confused.
So that's what I'm trying to explain. The white one, they are closed lesion. The black ones are open lesion. When they are opened, oxidizing agent can enter into those lesions, oxidize those content of the follicle, and it will make them appear blackish. Do you get it? So it is the oxidation that is making them blackish. But because the white ones, they are closed, they are not oxidized, so that's why they remain white. So but the take home is just that presence of comedones at all signifies acne. So
also, Dr. Babawale, you said the functions of the retinoids again, that they...
So the retinoids, they stabilize those follicles, they don't allow the keratin to occlude them, and they kind of facilitate the keratinocyte desquamation. So they regulate that keratinocyte desquamation so that they don't accumulate in the skin and be occluding the follicle. So they get shed. Once they are done with the activity, they get shed, they get released. So that's what the retinoids do. So, but I don't feel we need to pay attention to the mechanism of action. I'm just mentioning them so that we can relate it to the etiology. Knowing those medications is the one that is important. So the antibiotics to kill the cutis bacterium, the benzoyl peroxide to open those follicles and also kill the bacterium, and also retinoid to also help us open the follicles. So for atopic dermatitis, one thing I just want to point out with respect to this is that the lesion for atopic dermatitis are pruritic. That's like a hallmark feature of atopic dermatitis. And what we typically see in people with atopic dermatitis is, presence of erythematous lesion. So they have this erythematous lesion, particularly in a young child less than 5 years. You see the erythematous lesion usually within the face and the extensor surface of the body, like in the knee, the elbow, and the face. That's where you see those lesions. So it runs a chronic course. So it remits, then it comes up again. So it runs a chronic course, and it can persist till adulthood. So by the time the child is over 5 years, becoming older and maybe getting to adult stage, the pattern of the lesion changes. So you notice that the distribution changes to the flexural areas of the body, like the antecubital fossa, the popliteal fossa, the neck, the wrist, flexure areas. That's where you now find the lesions now, and the lesions are going to appear lichenified. They are going to appear thick, as if somebody has been scratching. Just imagine a skin that somebody has been scratching for a long time. That's what you are going to see. To now further nail your diagnosis, you might see the question, pointing out some form of atopic diseases. Like, in addition to that lesion, the child is also having history of asthma or allergic rhinitis. They are scratching the nose from time to time, having episode of asthma, the cough, chest tightness, food allergies, you know, you know, then married, you know, with the atopic dermatitis, the skin lesion, you know, this is classic for, you know, atopic dermatitis. Don't forget the flexural surface in children and adults, why you see it in the external surface and the face in small children. And because of the fact that it's more like an allergic disease, so there's increase in the level of IgE and eosinophils. Very, very important. We need to also understand the pathophysiology of atopic dermatitis. How does it happen? So it usually I share with problem with filaggrin. So there's a gene we call filaggrin gene, and the function of filaggrin is to form a barrier within the skin that contains a lipid matrix which prevents entry of microbes, environmental allergens into the skin, and it also helps to retain moisture. Now, people with atopic dermatitis, they don't have that filaggrin, so there's a problem with the filaggrin, and you tend to have introduction of environmental allergens and microbes into the skin. So that is what is responsible for the type 1 hypersensitivity, which brings about increase in the IgE, the eosinophils, that explains the condition. So that's why you also see it I share with other atopic diseases like asthma, allergic rhinitis. So filaggrin, very, very important. The reason why atopic dermatitis.
Please, can you tell that? Say that again, please. With the filaggrin, you said they are deficient in filaggrin. What's the point of the filaggrin?
So, filaggrin is like a protein that forms a barrier in the skin. It forms a barrier that helps to absorb moisture so that the skin doesn't get dried, and it also prevents entry of environmental allergen. Now, if somebody develops this atopic dermatitis, most likely there's a problem with the filaggrin. So that's why the environmental allergen could gain entry into the skin in the first place, triggering the hypersensitivity reaction, causing the IgE and the eosinophils to be elevated. Do you understand? Which brings about the skin lesion.
Okay.
Do you get it? So that's why it is very pyretic. Very, very pyretic. Then, I'm not trying to explain the reason why it's associated with ichthyosis vulgaris. So, ichthyosis vulgaris is another skin lesion that we are going to come across very soon. And it's also associated with problems with the filaggrin. But ichthyosis vulgaris one is just concerned more with the dryness. So the skin is very dry because I have said it that the filaggrin helps to retain moisture. So if there's no filaggrin, there's loss of moisture from the skin. So the skin appears very dry, thick, each scaly, it appears in breaks. We are going to see the lesion of ichthyosis vulgaris very soon. But we should know that it is related to atopic dermatitis or eczema, because both of them are shared with absence of the filaggrin protein. So moving on to allergic contact dermatitis. So this a part we usually get. We should know that as opposed to atopic dermatitis.
Sorry, Dr. Dobala, I have a question. Sorry.
Okay.
So with atopic dermatitis, because I've seen some, they say they have like weeping ones that have papules and vesicles on top of it. Those that is itching and also erythematous. And can you have the dry type of it like scaly? Sometimes you see some of them have some scaly skins around that area.
Yeah, you can. Why not? It's possible. Eczema can form scales. Most of all these things usually come from the intense scratching. So you see the skin looking scaly and lichenified. Let me see if I can get a picture so that you see. So in the early phase, the lesions might not appear scaly. They will appear kind of reddish and swollen because of the spongiosis. That's the acute one. But with time, when they start scratching the place, so because that it is an allergic stuff, histamine plays a role, you remember, and when histamine does its own action, what histamine is just there for is to cause vasodilation. So you have fluid extravasating into those tissues of the skin, so they will appear swollen, spongiosis. That's fluid feed stuff is what is causing the erythematous lesion initially. But with time, when they start scratching as they grow older. So you notice that the skin appears darker, thickened, and scaly. So let's see lichenification in allergic dermatitis. So that's why spongiosis is one of the early features of them. So you can see. So Dr. Antonia, can you see this? Look at this one now.
Yes, I can see it, yes.
So you can see the way it looks like. This white scaling, the lichen, the thickening, you can even see the skin lines. Look at this one. This is the one that's happening in the flexural surface. You can see. So that's likely to be allergic dermatitis. You can see this one here too. Very typical.
Kind of like
Yes, and you can see the tiny scales. This white stuff. So that is that about atopic dermatitis. So allergic contact dermatitis, as opposed to atopic, that is a type 1 problem, allergic contact dermatitis is a type 4 problem. So the skin is getting exposed to an allergic substance, that is causing the lesion. So this substance can be nickel, they can be poison heavy. So poison heavy is a form of plant, or neomycin. So neomycin is of course an aminoglycoside. So we can use neomycin topically. So that area that we apply this neomycin can develop a contact dermatitis. So nickel is a major component of some belts. So people that use nickel containing belts can develop allergic contact dermatitis in that area. So what happens is, because this is a delayed hypersensitivity type 4, this nickel, is going to be taken up, is going to conjugate with the proteins of the skin, because they are more like haptins. So they are going to conjugate with the protein of the skin, and they are going to be presented, by the antigen presenting cells of the skin, which are the Langerhans cells, to the lymph nodes. So the naive lymph nodes will now recognize those antigen, and they will now differentiate into the specific T cells that can respond to them. T helper, the T killer, both of them that are specific, they will travel to that area of the skin and stay there. They will be quiet. So that is the sensitization stage. So that one can happen for like 10 to 14 days. Then following re-exposure, you now have the lesion start appearing. So that one can occur within 24 hours. So the person wears that same belt again, because the CD4 cells are there already, the CD8 cells are there already, just attack immediately, So that is the elicitation stage. So you have two stages: sensitization and elicitation. So the lesions are usually confined to that area of, where you have the allergy in contact. So that's why I call it contact dermatitis. So you can see it around the belt area. So if you say a localized lesion around the belt, around the hair, maybe for people that are using hair rings, you might want to consider allergic dermatitis, allergic contact dermatitis. So I don't really encourage us to waste time on keratosis pilaris. Nobody's going to ask us this. It's not very common, but just change it as opposite of acne. So somebody having papules due to keratin plugging, but these ones are not located in the face, because you tend to see acne more in the face, in the back. So extensor surface of the arms and thighs, that's where you see keratosis. I think I have an image I will show us soon. Then melanocytic nevus. So these ones are very important. So the common mole. So these are more like benign proliferation of the melanocyte in the skin. So these ones they are like lesions that are benign. They are mitotically quiescent. They are not actively proliferating like melanoma. So they are like the benign form of melanoma. So they are melanocytes that are replicating, but not as aggressively as what we have in melanoma. So they have an homogeneous appearance, they have a well-defined border, and they grow in progression. So that's one thing about them. They are progressive. They are mitotically quiescent. They are not proliferating widely, and they show some progression. So what are these progression? So they start from a form and they end in a foam. So they start from junctional nevus. So nevus, that's a benign form of the mole. So benign melanocytes, that's a nevus or mole. So junctional one to a compound one to intradermal one. So to understand, because that's what the question is going to be focusing on, we need to understand what happens at the level of the microscopic view. We need to know what is happening. So for the junctional mole, you tend to notice that the melanocytes are confined to the epidermal junction or the dermoepidermal junction, the junction between the epidermis and the dermis. Can we see it here? So here, this area is the dermis. So the one above is the epidermis, and we can see that this one is just sitting at the dermoepidermal junction. And this is on microscopy. Why grossly, we are going to notice that the lesions will look flat, brown or black. They are flat, brown or black, because they are melanocytes. They'll be secreting melanin pigment, so which is going to impact the brownish or the blackish coloration, and it's going to be flat. Then they can progress to the compound nevus. So we can see that the compound nevus is already extending to the dermis, but we should remember that part of this nevus is still retained within the epidermis above. So it's sitting between the epidermis and the dermis. So if the question stem states that the lesion observed has both dermal and epidermal component, that is definitely a compound nevus. So as opposed to the junctional one, it's going to be elevated and it can be brown too, but to start losing its color because the melanocytes are no longer functioning as they should be. So it can still have some pigment, which is brown color. With time it will start losing and it will start fading out, but it will be raised. That's one thing we need to understand. It's not flat, it will be raised. Then that one too now can progress to intradermal nevus. So this one too will be raised like the junctional nevus, like the compound nevus, but the activity of the melanocyte is kind of gone. So the lesions are usually clear. They are not as pigmented, as dark or brown or black as the compound and the junctional. And it has completely left the epidermis, progressed fully into the dermis. So we call it the intradermal nevus. Please, do we understand this progression of this melanocytic nevus? Do we get it?
Sorry, Dr. Babawale, just to confirm again, the junctional nevus is at the dermoepidermal junction.
Yes,
right?
yes. So that means that it does not. So that means that it doesn't extend into the dermis. There's no dermal component. Do you understand? Hello?
Yes.
There's no dermal component. Okay. So I'm with you.
The compound one now has both. It's extending into the dermis and it has both the epidermal and dermal components.
That's correct.
So the intradermal doesn't have the epidermis.
It has lost the epidermal component. So that's that about the nevus. So
Okay, so Dr. Babawale, so with that, keep like the pigmentation, like the color.
yeah, so they will lose the color. They will lose the color with time. So you know that's why I said it's a progression. So the junctional one, they will still appear brown, black, because they still have their pigmentary function. The compound will some of them will be black, some of them will be kind of clear, light. While the intradermal, most of them will be light, because the melanocytes are losing their pigment forming ability. Do you get it?
Okay.
So, in addition to that, we must also remember the shape. I mean, the ones that are flat, the ones that are raised. So, compound and intradermal, they are raised, while junctional is the one that is flat. So, let us look at the image we have here and see what stuff we are dealing with. So, if image F is a mole, which one are we going to give it? Anybody?
Compound.
Can we say compound? Why? Why are you saying compound?
Like he said, If it is compound, that it will be raised and it will lose this color.
No,
No, intradermal, sorry.
intradermal.
Diadema.
Look, even
Intradermal will be raised and it will
lose the color. You can see that it's already it has lost its color. So going back, image F, we can see here that image F is intradermal. So they did not give us compound here, but there's compound. So they just gave us junction. You can see the junction now. You can see that the color is there, and this is flat. You can see. So, so that's what it looks like.
So, Dr. Babawale, please, so the congenital can be any of these three.
Yes. So they can be any of these three. They can be any of these three. So, so pseudofolliculitis Babé. So it's very straightforward. We don't need to waste our time. I think I have a picture. So pseudofolliculitis Babé is just talking about, painful pruritic erythematous, so we can see painful pruritic papules, around the beard area, this beard area, the chin, usually very common in men, around the jaw line, particularly when they are shaving. So this happens in people that have very coarse beards and curly hair, such that when they are shaving, the hair follicles, they turn back into the skin and irritate it. So that irritation is what is bringing about these lesions. So once you see these bumps like this, that is painful, itchy, in a bearded man, this is pseudofolliculitis Babé. We don't need to waste our time on it. That's the pathophysiology. So pseudofolliculitis Babé, that's that about it. So psoriasis. So psoriasis is something we must know. So I'm sorry, I've forgotten we have the images beneath. So we can see this child, we can see this erythematous lesion in this child. We can see the lesions in the cheek. So what do we think this is likely talking about? Erythematous lesion in the cheek of a child. Anybody?
Eczema. Atopic dermatitis, yeah.
Yeah, atopic dermatitis. So we can see the one affecting the flexure. So what's this? Image C. The flexure area.
I think it should be same thing too.
Yeah, same thing, but in an older child, right?
I meant what is
So same lesion, but in an older child. So you can see image D. So what is image D talking about? You can see the belt. So what's image D?
Contact dermatitis.
The contact dermatitis.
contact dermatitis.
So that's how they look like. So image F is also showing a contact dermatitis too. Maybe the person got exposed to the plant, and that's that. We can see image F and G talking about the navy. Then image H is psoriasis. So let's look at what psoriasis is all about. So what we just need to remember with respect to psoriasis is that they have plaques and papule. That's the lesion. So they have plaques and papule with what? Slivering scaling. We see the silver-like scaling, the whitish scaling like that, with the erythematous papule. So these are not even papule, these are plaques. In the extensor surface of the body, those stuff have to be there. The papules or the plaques with the slippery scaling, where in the extensor surface, like the elbow, the knees, the back of our hands, and the legs. So what are the macroscopic features of psoriasis? Because it's important in making the diagnosis. So acanthosis is there, and we have said it that acanthosis is when you have epidermal hyperplasia due to increased layer of the epidermis, particularly the stratum spinosum. So this acanthosis is what is giving rise to the plaque and the papule of psoriasis. Then in addition to that, they have parakeratosis and hyperkeratosis. So the parakeratosis and the hyperkeratosis are what is responsible for the slippery scaling. Psoriasis, because psoriasis is more like, it can be more like an autoimmune problem, in which you just have your T cells attacking the skin. So the T cells, um, the other component of the white blood cells, like the neutrophils too, can be seen. So we tend to see the neutrophils attacking the um, the tip of the dermis. So the tip of the dermis, you see some neutrophils, sedimenting within that area. So those are what we call the moral microabscess. So moral microabscess. So not the tip of it's actually at the stratum corneum. So that's where they accumulate. So they form the moral microabscess. These are just neutrophilic aggregates in the skin. Moral microabscess. Now, I'm sorry for the way my first aid is behaving. I think there's a problem with the first aid. So whenever they put maybe increase or decrease, it's going to replace it with comma. So what we actually have here is an increase in the stratum spinosum. That is what is causing the acanthosis, with a decrease in the stratum granulosum. So that is it for psoriasis. So stratum granulosum is decreased, stratum spinosum is increased, and also we have elongation of the dermal capillaries, such that when you try to remove this silver scaling, you notice that the skin will start bleeding because the capillary they will get ruptured. So that's what we call this auspit sign. So pinpoint bleeding that occurs maybe following abrasion, or when somebody tries to peel off the scales. Auspit sign is very typical for psoriasis. And we should not forget that psoriasis are shared with nail pitting as well as arthritis. So one of the seronegative arthritis, psoriasis is part. So we should never forget the papules, the plaque, with silver scaling at the extensor surface of the body. And for the microscopic feature, we see parakeratosis, hyperkeratosis, acanthosis, and of course elongation of the capillary, which brings about the auspit sign, as well as neutrophilic infiltration that brings about the moral microabscess. Rosacea. So rosacea is just when we have an individual having this flushing in the face. So there is erythematous flushing within the face, as well as presence of some papular rash, papular lesion in the face. It's very common in people that take alcohol, consumption of alcohol, people that are exposed to too much heat, sometimes cold, then exercise. So someone that exercises too much, get exposed to too much heat or cold, or takes alcohol. So we are going to get any of them in the history. Then to now make it very easy to get, we are going to get history of a bulbous deformation or destruction of the nose. So you can notice that the nose will become too big or kind of destroyed. So that is rhinophyma. You see the nose looks disfiguring. It looks very big. It's one of the complications of rosacea. Then they can have conjunctivitis of the eye, which will bring about some ocular problems. So conjunctivitis, rhinophyma, those are the complications of rosacea. That actually depends of erythematous lesion within the face with flushing of the face following consumption of alcohol, exacerbated by consumption of alcohol, exposure to heat or exercise, rosacea. So seborrheic keratosis. Seborrheic keratosis is best seen when you look at the lesion. In fact, it's not something that you can be describing with words. So we can see image K showing seborrheic keratosis. So what we just need to remember here is that seborrheic keratosis usually occurs as a well demarcated, a well defined, hyperpigmented, tanned color, lesion, maybe like a plaque or a purple with like a greasy like surface. And we have something that we call the keratin cysts, because this whole lesion is a form of benign proliferation of the keratinocytes. Immature keratinocytes proliferating, so they accumulate keratin within them. So these are those tiny things that we can see here. Those are the keratin cysts, and this lesion looks dark, hyperpigmented, well circumscribed lesion that looks like, sometimes they can look like warts. So it depends on what the question says. If they say they look warty, greasy, hyperpigmented lesion, and they not put this cauliflower appearance, because warts themselves too can look can look verrucous or warty, but they will say they look like cauliflower plants or something, and they will put some microscopic evidence too to it. But if you don't see the microscopic evidence of what, I'll just say, okay, keratin cyst, greasy, well demarcated, dark like this. This is seborrheic keratosis. Seborrheic keratosis. So occurs in so many people. So we can see abundance of this lesion in people with gastric adenocarcinoma, as a paraneoplastic manifestation. So people with multiple seborrheic keratosis, just like you can see in this individual's back. There's one here, there's one here, there's one here, there's one here, like that. We want to rule out gastric malignancy in this person, and they can ask us, what is this phenomenon? So this is a paraneoplastic phenomenon. Don't forget the keratin cysts, very important, because they are associated with proliferation of the immature keratinocyte. So verrucae, that's what. So they will look like this. So this is a very good picture showing the cauliflower like lesions, plaque, within the body. And what usually gives it away, aside that cauliflower of a tea, will be the microscopic finding. So they will tell us that microscopy, they were able to observe evidence of epidermal hyperplasia, acanthosis, thickening of the corneum, hyperkeratosis, and most importantly, choleocytosis. Why choleocytosis? Because these warts are caused by HPV infection. So the HPV infection is going to infect the epithelial cells and is going to transform them into the choleocytes. So choleocyte is a typical cell that has a thick, widened, enlarged nucleus with a perinuclear halo. You notice it's a clearance within the cytoplasm. So once you see that, that is a choleocyte. So it's typical of cells that are infected with HPV. So very, very important. It's highly suggestive for HPV infection. So the warts can be in the anus, it can be in the genital. That's what we call condyloma acuminatum. Urticaria. So urticaria are just like transient lesions, transient purple plaques that occurs in the skin, as a result of hypersensitivity reaction, type 1 hypersensitivity or allergic reaction. So it's caused by mast cell degranulation. So mast cells degranulate, release histamine. Histamine causes vasodilation, but usually within the superficial dermis. So it is the vessels within the superficial dermis that is vasodilating, allowing extravasation of fluid into those tissues within the superficial dermis, as well as the lymphatics. So the lymphatics that are releasing the lymphatic fluid, the dermal capillaries are also releasing their fluid into the dermis. So with time they get absorbed and the lesions clear away. Mind you, if this extravasation occurs deep into the dermis, like in the subcutaneous tissue, you don't call that urticaria again. You call it angioedema. So that's the difference. Similar pathophysiology, but different location. So the lesions are within the superficial dermis, urticaria, transient lesion. The lesions within deep to the subcutaneous tissue, angioedema. Same pathophysiology. So that is very, very important for us to remember. Mast cell degranulating, causing lymphatic channel dilation as well as dilation of the capillaries within the superficial dermis, bringing about the edema. So moving on to the vascular tumors of the skin. So the first on our list is the angiosarcoma. So what do we mean by angiosarcoma? So angiosarcoma is just...
enlarge your screen, please.
So sorry about that. So angiosarcoma is just a malignant tumor of the vessels. So malignant tumor affecting the endothelial cells of the vessels. Angiosarcoma usually occurs within the skin. Most of the time it occurs in the skin. And if it occurs in the skin, most of the time it occurs in the head and the neck. That's it. It can occur in the breast too. So, but the pathophysiology of the one that occurs in the breast usually follows a prolonged period of lymphedema. So it can occur in the head and neck, maybe due to increased exposure to sun or from old age, they can develop it. But people that develop it in the breast, it's usually due to prolonged lymphedema from post-mastectomy, in which the person has undergone a radical mastectomy. They have removed the breast, they have removed the lymph nodes, and there's problem with clearing of and draining of the lymph. So there's stasis within the axilla and the upper limbs as well. Or the person has gotten exposed to radiation therapy for a long time, leading to fibrosis of those lymphatic, channels, causing the lymphedema. So that will cause irritation of the vessels, the endothelial cells there, and they will undergo a malignant transformation, leading to angiosarcoma. So what do we see? We can see the patient presenting with some purplish lesion. Some of them can look like someone that has bled into the head or the breast. They will look like, extravasated blood. Sometimes they can transform into nodules. The nodules can even ulcerate and it will become fungating. Angiosarcoma. So we should not forget this Stewart-Travis syndrome, which is cutaneous angiosarcoma developing after chronic lymphedema. Very important stuff. Then we can also have hepatic angiosarcoma, which is different from the cutaneous angiosarcoma. So that one happens in the liver, and it is associated with exposure to polyvinyl chloride, either from pipe plumbing work or arsenic exposure. Very important. So bacillary angiomatosis throws another vascular problem. So here we have abnormal proliferation of the capillary beds, and they will appear like red, purple. So we can have red to purple looking purple. I think we have a picture. So this is it, image A, like this. But what is going to help us is that the question stem might put in there that the person has a background HIV and the CD4 count is less than 100, because this is one of the hate defining illness. So less than 100 CD4 count, reddish purple like this, and the person, they could put it there that the person had exposure to animal scratch, like cat scratch, and the organism that is responsible for this lesion gets inoculated into the skin, into the body, which is a Bartonella infection. So Bartonella ensele, Bartonella quintana, all those things can cause the lesion. So it's very, very confused with Kaposi sarcoma. But on biopsy, we are going to see predominance of neutrophilic infiltrate as opposed to Kaposi, which is going to be more of lymphocytic infiltrate. And in Kaposi, you don't need to have the white blood cell count being less than 100. Less than 500, less than 200 is enough. So less than 500 for the cutaneous Kaposi, less than 200 for the disseminated Kaposi. So cherry angioma. So what we are just looking at for here is an adult, with this reddish lesion that we can see in image B, reddish purple.
Sorry, Dr. Babawale, saying I didn't get the less than 500 that you said. Which one?
That is taking us back to our microbiology. We remember that we talked about the lesions in 8 that appear as the CD4 count comes down. We said when it's less than 500, there are some lesions that we see. Abi, Dr. Antonia, do you remember them? When they are less than 500?
Yes.
Yeah.
Yes.
So cutaneous Kaposi is there. My happy Kaposi, I think that was the acronym, my happy Kaposi. So we are talking about the oral lesions first, the oral hairy leukoplakia, the oral candidiasis, then my happy Kaposi. So mycobacterium tuberculosis reactivation, my happy, that's the papilloma virus, so oropharyngeal cancers, warts, then the Kaposi, cutaneous Kaposi. So that is it. But for Bartonella, this bacillary angiomatosis, they usually occur when the CD4 count is less than 100. So that's where they fall in. So do you remember it now, Dr. Miriam?
Yes, I do. Thank you.
So cherry angioma, reddish lesion like this, raised, increasing with age, not regressing in size. That is characteristic for cherry angioma. In fact, that's what we just look out for in the question. Is this thing increasing with age or increasing in size? Or doesn't reduce with size, with age? It doesn't regress, it doesn't reduce. and the stuff is occurring in an elderly person, in an adult. Cherry angioma. So the glomus tumor, these are just proliferation of the vessels, the modified smooth muscles within the glomus body. So what are the glomus body? So the glomus body are just like thermoregulatory organs within the nail bed. You can see it in the nail beds, you can see it in the hair. So they are there to detect the temperature. So once they notice that the temperature is too cold, they want to vasoconstrict so that you don't allow too much blood to be, shoveled to the skin, and you don't allow it to be dissipated out. But when the temperature is too hot, they want to vasodilate the vessels. So they mediate vasodilation of the vessels so that you can have more blood flow and you can have more heat dissipating out of the skin. So that's the thermoregulatory function of the glomus body. So they can undergo some, neoplastic transformation, and they can form the glomus tumor. So you see them appearing like this blue red tumor that are painful in the fingernails. The reason why it's blue red is because they contain the arterial end and the venous end, then the muscle in between. That is it. So the arterial is red, the venous is blue. So Kaposi sarcoma is just like the bacillary angiomatosis. So you see the purple violaceous lesions, the nodules, the plaque, that are reddish, but most of the time they are purplish, in the skin. And if you do a biopsy, you are going to see lymphocytic infiltrate. It's very common in people that have HIV, just like we have said. For the cutaneous one, when the CD4 count is less than 500. For the disseminated one, the one that affects the lymphatic tract, the one that affects the GIT, the lungs, they typically occur when the CD4 count is less than 200. If you do the biopsy, you are going to see lymphocytic infiltrate, and of course, the perivascular spindle cells, which are talking about the endothelial cells that are proliferating. So it can be sexually transmitted. The virus that causes it, which is a human herpes virus 8, Kaposi sarcoma virus. And of course, because we said it's one of those 8 defining illness, it's very common in people with HIV. So pyogenic granuloma, we should not worry too much about that. This, represented by image D. We just see raised elevated lesions that occur in people that are pregnant or in areas that have suffered extreme friction or abrasion or trauma. So if you are moving a part constantly subjected to friction too much or trauma, or in a pregnant person, they can develop this lesion like that. Usually you can have it around the mouth, in the face, and they bleed easily to touch. Pyogenic granuloma. So don't typically get more questions on it. The ones that are important there.
So Dr. Baba, they develop with this friction to a part of the body.
The what?
The pyogenic granulomas.
The what?
So are you saying that they develop with increased
yes.
Friction?
With increased friction, yes. They can develop with increased friction, or any area that is subjected to trauma or due to effect of pregnancy. So you can have it. So that's that about it. It just bleeds easily. That's it. So the strawberry hemangioma, that's the infantile hemangioma. So this one is very easy to remember. So this one, as opposed to the cherry angioma, it's a benign proliferation of the capillaries too. So you see the lesion like that, the skin of the baby. It occurs after some few days or few weeks after birth. Then after the age of 5 to 8 years, it will regress, unlike the cherry angioma that do not regress. So that's infantile hemangioma or strawberry hemangioma. So moving on to the skin infection. We have the bacterial and the viral. Most of the viral, we already know them. So the bacteria, they are classified based on the level of affectation. So the impetigo is the first one. What we are just looking out for impetigo is just honey colored crust. In fact, once you see that in the question stem, that is impetigo until otherwise proven. So impetigo is a bacterial infection of the superficial part of the epidermis. So it is highly contagious. So people that work in close contact, daycare, because it's very common in small children. So daycare, they can easily transmit it from one child to another child. I see these lesions that burst open, the purulent exudate is released, and the crust becomes dry over the skin, and it will appear just like this. You can see this yellowish, crusty. So that is impetigo, and we can have two forms: the bullous impetigo and the non-bullous impetigo. So the bullous impetigo is usually caused by Staph aureus. The non-bullous, you can think of strep pyogen, the group A strep. Group A strep. Bullous Staph aureus. So erysipelas. Erysipelas is deep compared to impetigo. It affects the superficial aspect of the dermis, not the epidermis now. The dermis, as well as the lymphatics, because most of the lymphatics are even deep within the dermis. Just like urticaria, affecting the vessels in the dermis and the lymphatics there. So erysipelas affect the lymphatics and the dermis of the skin, the upper dermis. And the most common cause of erysipelas is just group A strep, is strep pyogen. How do you identify them? You will see erythematous lesion, that is raised and well demarcated. You can see that you can maintain an outline in this lesion. Painful lesion, well demarcated, erythematous, erysipelas. Next organism, strep pyogen. So for cellulitis, they are deeper. They penetrate down the dermis, even to the subcute. Cellulitis, it gets to the subcute. So this is more like a soft tissue lesion. So cellulitis can occur from superimposed impetigo or erysipelas that becomes secondarily infected or progresses to the subcutaneous tissue and the deeper dermis. You can have it in people that are always, using drugs intravenously. That side, puncturing that skin, cellulitis. People that have trauma, there are some other risk factors to immunosuppression and the likes can lead to cellulitis. So what I just want to mention here is that the lesion in cellulitis are not well defined. You cannot mark out the border definitely. So they are irregular in terms of the outline. So they are not well circumscribed like erysipelas. I see all the cardinal signs of inflammation. So it's red, it's painful, it's swollen, it's warm, and it's very deep. So most of the time you can have two forms. You can have the purulent form or the non-purulent form. So if it's the non-purulent form, you might want to think of the group A as the infectious cause. If it's the purulent form, in which you are going to be seeing fluctuant mass, you can think of Staph aureus as the cause of cellulitis. So you can have formation of abscess. The abscess is just like a cavity within the skin where you have collection of pus. So the most common cause of abscess is Staph aureus. So abscess, collection of pus, within the skin, abscess, Staph aureus. Then necrotizing fasciitis is also another, lesion to pay attention to. This is a more deep injury compared to cellulitis. It's getting to the superficial fascia now. The deep fascia, the superficial fascia are being infected in necrotizing fasciitis. So just from the name, necrotizing fasciitis. So there is necrosis of the tissue, the fascia. So what do we see at first? We can see bullous lesion. Bullae, that's the first thing you see in the question stem. So you see bullae. The bullae are not kind of very evident in this image F because they have ruptured, so it has been opened. So you notice the bullae, and secondly, you notice the abnormal discoloration of the skin, because one of the major pathophysiology is recurrent formation of thrombus within the vessels. So that thrombus occludes the vessels and compromises blood flow to the tissues, to the facial, to the skin. So they become necrotic and they become discolored. So they look blackish, purplish, like just what we have here. And of course, because of the infection, they are anaerobic infections most time. So they produce this putrid, foul-smelling discharge. And what can help us, give it out quickly is the presence of gaseous tissue, gaseous collection. So because of the gas that accumulate there, you can hear crepitus. So once you see bullous discolored lesion that are sometimes they might not be painful, because that thrombosis that I've talked about would have damaged the nerves. So sometimes they can be painless. They can be painless depending on the extent of the injury. But the ones that are always constant there, this bullous lesion that can rupture the discoloration of the skin, which looks brownish, purplish, or blackish sometimes. And depending on the microorganism involved, if it's like Clostridium perfringens, you are going to see gas collection in the tissue planes, which is going to bring about the crepitus sound as if they are stepping on leaves. Once you see that, you are able to demonstrate that you are dealing with necrotizing fasciitis. So you see gas being collected, resulting in crepitus from methane or CO2 being produced by the anaerobic bacteria like Clostridium perfringens. Sometimes it can be caused by by strep pyogen infection. So very important. Before the nerves have been destroyed, there might be pain, and the pain will be out of proportion to the exam finding. You are just looking at the lesion, small lesion like this. You touch it, the person is already shouting, out of proportion to what you are seeing. So we should not forget, it's a surgical emergency. We need to remove the necrotic tissue and place the person on antibiotic. Very, very important. So don't forget, anaerobic bacteria like Clostridium perfringens or strep pyogen, most of the time it's going to be anaerobic bacteria like Clostridium that they are going to put there. So staphylococcal scarlet skin syndrome is the last year, staphylococcal scarlet skin syndrome. So just like the name, Staphylococcus is the implicating organism. How? It releases a toxin, the exfoliative exotoxin. Hey, what does it do? That toxin inhibits or attacks the desmoglein 1 and 3 within, the epidermis of the skin, which is the desmoglein that helps to attach the stratum spinosum to the stratum granulosum. So you have that epidermal cleavage and separation. So very, very important stuff. So how do they present? So it typically occurs in small children, very small children, newborns or young children, or adults with renal insufficiency. So it's very common in people with renal compromise. That's just epidemiological finding. We don't actually know why, but it's common in people with renal compromise. But most commonly you see it in newborns and babies, children. How would they present? They have high fever with a generalized erythematous rash. This statement is very important. Generalized erythematous rash that you typically see in the face as well as the intratriginous areas of the body. Those are the things you are looking out for. So you can see the lesions in the axilla, in the neck, in the groin. So the groin, intratriginous area, the axilla, the neck, the face, and they are scalded, very painful to touch, and they easily separate. As you are touching it, they are shedding off. That's what we call the Nikolsky sign. So you apply small pressure, it is kind of separating, it's kind of shifting. The skin is sloughing off. Nikolsky sign. It's very typical for SSS. Yeah. So most importantly, to separate it from its closest differential, which is TAN and SJS, it does not involve the mucosa. So it will not involve the mucosa of the mouth. You can have periocular crusting, but it will not touch the mucosa, which is this part of the, this mucosa here, will not be affected. So once you see the question saying no problem with the mucosa, you cancel staphylococcal scarlet, you put staphylococcal scarlet syndrome in your mind since it's not involving the mucosa. But once they put it there that the mucosa is affected, then you know that staphylococcal scarlet skin syndrome is not a possibility. So fever, diffuse erythematous rash, which peels off easily within the face, the intratuginous area in a small child, thinking of, staphylococcal infection. Don't forget the Nikolsky sign, and don't forget the closest differential, which is toxic epidermal necrolysis, which can also present similarly the fever, the rash, but you typically get history of maybe a previous infection which is not Staph aureus, maybe mycoplasma, or most commonly use of some medication. So like allopurinol, like sulfonamide, like the anticonvulsants. Very, very common. And of course, the lesion will affect the mucosal surface. So that's how you separate them. So for the viral infection, we have the herpes. We already know this from microbiology. Herpes 1, herpes 2, both of them can cause infection in the mouth, the vesicular infections in the mouth, the gingival stomatitis, herpes labialis. Then for HSV2, it can cause genital ulcers. They can also cause whitlow. By the time the person puts the hand in the mouth, from gingival stomatitis, herpes labialis, now putting hand in the mouth again, you can spread the herpes to the fingers and it can lead to hepatic whitlow. So, Molluscum contagiosum, we know what it looks like. So this is caused by a pox virus, a DNA virus, which can cause Molluscum contagiosum with a purple that has a central indentation or umbilication. So that's what to watch out for. Varicella zoster. Varicella zoster can cause chickenpox or shingles. So the initial lesion is chickenpox, in which they are going to tell us that we have lesions starting from the trunk, moving outwards to the extremities and the head, and they occur in different crops, different evolution. So most of them will be vesicles, and they will progress to papules, and they finally crust at the end of the day. When they crust, they become latent in the ganglia. So they can become latent in the sacral ganglia, they can become latent in the trigeminal ganglia, in the dorsal root ganglion. So they stay there, and when there is a form of immunosuppression, HIV, use of steroids, transplant, you can have reactivation of that latent virus, and by this time it's going to come out as zoster. This time you are going to have the vesicles having a dermatomal distribution. So if it's disseminated, I can cross dermatome. So you can have it to one dermatome and that dermatome, opposite dermatome, both affected. So that's disseminated from. So that's herpes zoster. Then hairy leukoplakia, so caused by Virox, Epstein-Barr virus. So what does it look like? So you see whitish lesion, at the corner of the tongue, which appears hairy or corrugated. That's it. So the question is going to tell us that the lesions are corrugated or hairy. So you want to consider oral hairy leukoplakia, Epstein-Barr virus infection. So it's very, very close to oral thrush. So which is caused by Candida, because in oral thrush you can scrap it off without bleeding, but this cannot be scrapped from the tongue. So the third lesion that looks like this is what we call leukoplakia, ordinary leukoplakia. So this is just a white patch in the body which has no other definable cause. So we cannot say this is, if we say a lesion that is not corrugated, and we cannot call it oral hairy leukoplakia, and it's not like Candida. So if you biopsy it, you are not seeing the pseudohyphae of Candida. So that is definitely a leukoplakia. So that is a precancerous lesion that is very common in people that take alcohol, people that smoke, or people that chew tobacco. So they can develop leukoplakia, which is a pre-cancerous lesion that can progress to developing, into squamous cell cancer. Very important. So moving on to the cutaneous mycosis. So these are this encompasses dermatophytes as well as pityriasis versicolor. So the dermatophytes are known as the tinea. So dermatophytes meaning they have tendency to invade keratin containing tissues. They feed on keratin. That is it. So we have three of them: the microsporum, the trichophyton, and the epidermophyton. So the commonest one here is a trichophyton. So that is one that is responsible for most of the lesions, the dermatophyte. So how do we identify them? You can see the branching septate hyphae on the KOH variation. But one highlight about them is that they are very pyritic and they can be scaly. Pyritic, scaly. So we know that aspergillus is not pruritic. So that's another thing for us. Pyritic. So what are these spectrum of infection that they can cause? So the first one is tinea capitis. So they can cause some lesions. So these are the branching septic hyphae on the KOH mount. So this tinea capitis, so the tinea infection, the trichophyton, is infecting the head. What do we see? We see some scaly lesions in the head. Sometimes they are round. You see round, scaly lesions. You can see this white scaly, in the head. Because of the fact that they invade the keratin, they can easily break the follicles, leading to alopecia. So you can see the hair loss, alopecia, scaling, tinea capitis, very itchy. You'll be scratching that head from time to time. Tinea corporis. So this is when the lesion affect the body, and the lesions are quite different from that of capitis. We just see the circular lesions with central clearing. So when you say the person has circular lesions with a central clearing, then want to consider possibility of tinea corporis. Then moving on to the third one, which is tinea cruris. So that's when the tinea infection affect the intratriginous areas of the body, like the groin. So this one is quite different from tinea corporis because the erythematous lesions don't have the central clearing. So they have no clearing. They are just there like that. It looks like diaper rash. So it looks like diaper. There are so many differential for diaper. It can be candida. It can be due to maceration. Maybe the baby has peed in the diaper too much. So that can macerate the skin and lead to the rash. But that one usually spares the inguinal folds. While that of candida or from this guy here, dermatophyte, they don't spare the inguinal fold. They will affect every part, So, and you will not see the central clearing. So that's, the tinea capiti, cruzi, very itchy.
Sorry, Dr. Bobo, he said the diaper.
Yes, so I just said it looks like diaper rash. Hello, can you hear me? So I said we can have diaper rash from constant soaking of the diaper.
No, sorry, my network is fluctuating. My network is fine. I wanted to ask you a question. You said something about diaper rash in children that it spares the groin or something.
Yes.
So
when these babies have their diapers on and they pee or they defecate into these diapers, so that area of maceration, can get infected with some bacteria, particularly all these bacteria that contains urease. So they can alter the pH. They can alter the pH of the skin because ammonia is going to retain in that area and the pH will be elevated. So that can irritate that skin. With the pH changes, can cause inflammation, which will irritate the skin, and they can have this rash, within that skin. But it's going to spare the area that is not in contact with the diaper. The diaper doesn't usually touch the inguinal line. This line. Do you get what I'm saying, Dr. Antonia? So you know that one is from that diaper, blah blah. But if you see another one that is affecting everywhere, both the inguinal line everywhere, so that is most likely in a child. You can think of candida. Then it can also be this one too, this dermatophyte. But dermatophyte is more very common in adults, like adult people. Those are the ones that usually have these dermatophytic lesions. So
don't forget it lacks the central clearing. So don't say that because you do not see central clearing, you will not go and pick tinea cruris. So once they do the biopsy of the lesion and they saw branching septic hyphae, not pseudohyphae, branching septic hyphae, this dermatophyte, tinea cruris. Then the second to last is the tinea pedis. So when you have the tinea infection affecting the foot, so you have three types: the moccasin, the interdigital, and the vesicular. So the commonest form is the interdigital, in which you have the tinea infection affecting the cleft in between the toe. That's it. So you just see that area looking scaly, fissured, rough, like what we have here. So that's, tinea pedis. That's the interdigital type. You can have the moccasin type. So moccasin type is also known as a plantar type, which is what we can see in image F. It usually affects the sole or the edge of the sole, just like we can see here. And we have the vesicular type. So in the vesicular type, they are just talking about the presence of vesicular lesions, within the foot. That is just it. But pay attention to the interdigital and the moccasin. Very important. They can ask. So tinea pedis, that's that. And tinea unguum is the last one, which is when you now have the tinea infection affecting the nail. So they affect the nail. They can cause so many changes within the nail. It can appear yellowish. The nail can appear thickened. They can even break off. So that's what we call onychomycosis. So that's, a tinea infection. Tinea unguum. Discolor the nail, make them appear thickened and broken. So the last is the tinea vesicolor. Tinea vesicolor is not a tinea infection. It's just a misnomer. I just call it that way because it doesn't have predilection for keratin. In fact, it is not caused by Trichophyton, Microsporum, or Epidemophyton. It is caused by Malassezia. Who remembers what we said Malassezia also causes? Anybody remembers?
Seborrheic dermatitis.
Yeah, so seborrheic dermatitis. So this pityriasis versicolor is what we Yoruba people call ifo. So this is just a lesion of the skin that is associated with areas of hypopigmentation. Most commonly, you see hypopigmented areas alternating with normal skin. Why? Because what happens is that Malassezia globosa, when it infects that skin, particularly in an individual that is constantly sweating, maybe due to the humidity, so humid region, warm region, as person is sweating profusely, they can easily, be a potential site for this fungi to come in, and it's going to feed on the sebum, and convert it to what we call azelaic acid. Now that azelaic acid inhibits the activity of thyroxinase. So thyroxinase will not be able to catalyze production of melanin again, and melanin is one that impacts the color to the skin. So the skin will appear hypopigmented. So once the area of hypopigmented in the chest, the face, the back, we know that is likely to be tinea vesicolor. Sometimes they can also have some area of hyperpigmentation due to inflammation to the organism. So don't forget, it's very common, sweaty condition, humid region, summer, very important. And you see areas of hypopigmentation in the chest, the face, the back. So once we do the biopsy on microscopy, we are going to see what we call the spaghetti and the meatball appearance on microscopy. Once you see that, spaghetti, meatball, spaghetti, meatball, spaghetti, meatball, that is tinea vesicolor, and that is just demonstrating the yeast. The yeast are the clusters of the balls and their filament. So the filament is the spaghetti. The clusters of the yeast are the meatballs. So what do? Give antifungal agent like ketoconazole, or we can give selenium sulfide. It works, towards curing that infection. So moving on to the autoimmune blistering skin disorders. Two major types, the pemphigoid vulgaris and the bullous pemphigoid. So the bullous pemphigoid and the pemphigoid vulgaris. So what is the pathophysiology? we must remember that both of them are type 2 hypersensitivity problems. I don't really like talking about the age because both of them are actually very common in older people. But the thing is just that in bullous, it occurs more in older, maybe someone more than 70 years. But pemphigus too occurs in people that are old, 60 years and above. So that age is not really a clincher. Both of them old people. But it's the presentation of the lesion that is going to give it out. So they are type 2 hypersensitivity reaction because it is antibody that is causing the problem. So which antibody? IgG, but against different components. So the pemphigus vulgaris is antibody against the desmosomes, particularly the desmoglein 3 and the 1 of the keratinocytes. Why? For bullous pemphigoid, it is due to IgG antibodies against the hemidesmosomes. Where did we say the hemidesmosomes are located at? Who remembers? Anybody remembers? Yeah, so at the basement membrane. Very, very important to remember where they are located so that we can understand the microscopic findings. So the pemphigus vulgaris destroy the desmoglein within the epidermis, particularly between the stratum spinosum and the stratum granulosum. So you have epidermal sliding, cleavage along that area. So what do we see grossly? Now, because of the fact that the cleavage for bullous pemphigoid occurs at the basal membrane, so it means that we are elevating, the basal cells of the epidermis, splitting it from the basal membrane. We can see this diagram. So this is where, the splitting occurs. It is a splitting that is, just in between the basal cells of the epidermis and the basal membrane. So we can call that like a suprabasal, it's not suprabasal. So suprabasal will be for this. I've forgotten, the nomenclature. There's a way we call it. I've forgotten. If I remember, I will. But we should know that it's between the basal membrane and the basal cell of the epidermis. So this is where the fluid will start collecting. Now, if the fluid collects here, that fluid cannot rupture because the basal membrane will provide support for it. It will become tense. So that is why the blisters for bullous pemphigus, they are tense. They are not easily ruptured. And the Nikolsky sign does not work here because for the direct Nikolsky sign, once you place your hand on the skin, it will rupture. It will separate. That doesn't happen in bullous pemphigus because the blisters are tense. And don't forget, the oral mucosal has spared. In pemphigus vulgaris, the lesion is located in between the epidermis here. So we can see the areas where the splitting is happening. So in between, like this, in between. So the epidermal cells cannot cushion themselves to provide support for the blister. So it's flaccid and it ruptures easily. Flaccid blisters affecting the mucosal cell ruptures easily. Pemphigus vulgaris. So what do we see when we do H&E staining? Now, when we do H&E staining for pemphigus vulgaris, we are going to see the tomb of roll or the roll of tomb cells. What they are telling us is that they see like tomb that are arranged in rows. What are these tomb? These tomb are actually the basal cells, because from this diagram that we have here, we can see that the tomb, they are kind of sitting on the basal membrane and they are intact because the problem is not at the level of the basal membrane. So the basal cells are firmly attached to the basal membrane, while the ones that are suprabasal, that's why they call this one suprabasal split. The epidermal layer between the granulosum and spinosum are the ones that are shifting. So that's where we have the spaces. So that area, is going to look disfigured, while we are going to see the intact arrangement of the basal cells along the basal membrane. So that's what brings about the tomb or the roll of tomb appearance. So once you see that in the question, that is pemphigoid they are talking about. Now, what now gives it out completely? And don't forget, the Nikolsky sign will be positive. You apply, pressure, the epidermis will be shifting. So, immunofluorescence is the last investigation. So, immunofluorescence, we are just, looking at antibodies arrangement, with our microscope. That is it. Now, we remember that in pemphigus vulgaris, the antibodies are interspersed, in the cleft in between the what's it called? The separation within the stratum spinosum and stratum granulosum. So stratum spinosum, stratum granulosum, that separation, that's where the antibodies are located at. You can see, just like we have in this image. So it means that when we try to look at this antibody, they are going to give this reticular configuration. But if we look at the antibody distribution for bullous, it's only going to be confined to the space in between the basal membrane and the basal layer, which is like a linear gap. So it's not reticular, it's not scattered like in pemphigoid. So this one is linear. So when we observe it, we are just going to see the split, which is going to be linear, just like we have here. We can see here, this is probably the basal epithelial cells, and maybe this is a basal membrane. We can see the split at these spaces here. So this is a linear pattern. So this is classic for bullous pemphigoid. But we can see this one. It looks like hole here, hole there, hole here, hole. You can see reticular. Just like shaki meat. For some of us that eat meat, shaki. You can see the reticular fishnet kind of distribution. So that is, immunofluorescence pattern for the pemphigoid vulgaris. So we should not forget. We can see these lesions already becoming ruptured. It means they are flaccid. So this is pemphigoid. But we can see this one, they are still intact, staying. This is bullous pemphigoid. So please, hope we understand this bullous pemphigoid and the pemphigoid vulgaris very well, and we can state their microscopic findings. Please, are we there? Or there's any area that is not clear? Hello, there's no
I
response.
understand.
There's no response.
I understand.
Okay.
But we're giving you thumbs up. Apparently, you can't see it.
The what?
We're giving you thumbs up. So it seems
Okay. Sorry. I'm not looking at the... I don't want to minimize my screen. Sorry, I'm not seeing them. Thank you. So, the last one is the epidermolysis bullosa simplex. So this one is a little bit complex. But what I'm just going to tell us is we just have to know, just have in mind how the presentation looks like. So, epidermolysis bullosa simplex is, very common in young children. It's not like in old people like bullous pemphigoid and, pemphigoid vulgaris. Very common in young people. So, it's due to a mutation, autosomal dominant mutation in a gene that encodes keratin filament assembly. Now, what we are talking about here is that normally, as they are producing the keratin are supposed to be assembling together in bundles so that they can form a filament. That's it. They're supposed to be coming together so that they can provide a cytoskeletal support for the epithelial cells within the skin, the keratinocyte. But in people with epidermolysis bullosa, you don't have that keratin assembly happening. So the epithelial cells, the keratinocytes, they are not strengthened by this keratin. They are not. They are weak. They can be separated easily. But where do you typically have this lesion? In the question stem, you are going to be seeing a young child that have separation of skin lesions or blisters within the palm and the sole. Once you have that, just go for epidermolysis bullosa simplex. That's it. Blisters that easily, ruptures in the palm and the sole, and they heal without scarring. That is epidermolysis bullosa. So they are so fragile that with minimal friction, the baby is trying to walk, they are rupturing. it can even affect the mucosa of the mouth, so that when you try to bottle feed, you have these lesions bursting. Epidermolysis bullosa. It's not autoimmune involving IgG, but it's a genetic problem that's affecting the assembly of the keratin filament within the keratinocyte. So once you do the biopsy, they will tell you that there's kind of intraepidermal cleavage. Marry all those things together, that is epidermolysis bullosa. The other blistering skin disease. So dermatitis epiphyseal, we are very familiar with this guy. So for this one, you typically see myriads of lesion. You can see purple, you can see vesicle, bullae, but they are puritic. That's the first thing to remember. Dermatitis epiphyseal, puritic lesion, puritic purples, vesicles, bullae that are present within the extensor surface of the body. So like the elbow, the knee, the buttocks, and it is closely related to celiac disease. So they can paint a situation of someone that has celiac disease, abdominal pain, diarrhea, malnutrition, steatorrhea, celiac disease, and maybe they did the biopsy of the GIT and they saw venous atrophy, crypt abscess, intral epithelial lymphocytosis, all those things for celiac. That is likely to be dermatitis epiphyseal. Let's just talk a little about how it happens. So now, remember, someone with celiac disease, they are very sensitive to gluten. So when they eat gluten, the gluten is absorbed in the GIT, and when it gets to that GIT, there are some modification that happens. So there's an enzyme that we'll call tissue transglutaminase. So the function of that enzyme is to convert. So gliadin is a gluten. So it will deamidate this gliadin. So it wants to deamidate the gliadin. That's what the tissue transglutaminase is doing. So when it catalyzes that reaction, so in people that are sensitive to that gluten, what will happen is that gliadin, that deamidated gliadin, is going to be cross-linked by covalent bonding with the enzyme, the tissue transglutaminase, and you start having antibodies being produced against them. So because the body will start to recognize that product as being foreign. What the hell has just happened? Why is this one coupled to this one? I beg, call those antibodies, let them come and eliminate these guys. So that's how the autoimmune problem kicks in. And you tend to have, IgA, because this is a mucosal problem. So the immunoglobulin that's going to respond is not going to be IgE. So it's going to be IgA and IgG, predominantly IgA. So the IgA will be attacking, the deamidated gliadin. So that's why you have antibodies against deamidated gliadin in celiac disease, and at the same time, IgA against the tissue transglutaminase are going to be produced, attacking this tissue transglutaminase. But the problem is that the IgA against that tissue transglutaminase can cross-react, and attack transglutaminase that is present within the skin, because that enzyme is present also in the skin. So it will start attacking that of the skin, and it brings about this lesion. So you notice that the IgA will be deposited within the tip of the dermal papillae, because the dermis has two layers, the papillary dermis and the reticular dermis. So you notice that these IgA antibodies will be depositing within, the papillary aspect of the dermis. They'll be recruiting neutrophils and other white blood cells, which is going to mediate the inflammatory response that brings about these skin lesions, which appear like purples, vesicles, bullae, leading to dermatitis epiphyseal. So what do you do to treat them? Stop the initial problem. Stop giving that person gluten. The person should be gluten free. That's one. You cannot stop the gluten. You need to stop the inflammatory response by giving dapsone. So dapsone will reduce the inflammatory response and will subside the lesions. Very important. So erythema.
Dr. Bade, like, if I understand what you're saying, so is the IgA antibody against the tissue transfer.
Hello, I can't hear you.
That is not training the, yeah. Sorry, network is fluctuating. I said is the antibody against the tissue transglutaminase in the skin that is then triggering inflammatory reaction.
Yeah, so that antibody produced in the GI is what is reacting with the, is what is attacking the enzyme in the skin. So
The skin.
it's trying to so it's now deposited within the regions of the skin, such as the tip of the dermal
So
papillae.
it not triggers inflammatory reaction, right?
Now trigger inflammatory reaction that brings about the presentation. So that is it. So erythema multiforme. Erythema multiforme, what I just want us to remember about this is that they typically have this. So this is the lesion for dermatitis. You can see this tiny purple, in the elbow. This should be the elbow. So for erythema multiforme, you have targeted lesions, with a central dusky area. So that dusky area usually is bullous before it ruptures and becomes dusky, brownish. So once you see erythematous area with a central dusky area, highly specific for erythema multiforme. So most of the time it follows infection. So somebody has lung infection, erythema multiforme, you are thinking of mycoplasma pneumoniae. So somebody has some vesicular infection somewhere, maybe gingival stomatitis, you want to think of HSV as a cause of that lesion. So HSV is actually the commonest cause of erythema multiforme, then followed by mycoplasma. Then it can follow use of some drugs, beta-lactams, sulfur drugs, phenytoin. So most of the time, sulfur drugs and phenytoin will be correct because these sulfur drugs, anticonvulsant, they can cause Steven Johnson, they can cause erythema multiforme. So once you are trying to remember drugs that causes all these rash problems, sulfur drugs will be correct, anticonvulsant will be correct. So don't forget targeted lesions, central dusky rings, erythema multiforme. Then Steven Johnson, just like I've said, they present similar like Staphylococcus scarlet skin syndrome. So you just see that patient have this diffuse rash, fever, hypotension, and all those things. Then you notice that the lesion affects the mucosa. It doesn't spare the mucosa. And definitely we are going to get history that the person has used some medication, sulfur drugs, anticonvulsants, allopurinol. They can all trigger the Steven Johnson syndrome. So this one is due to cytotoxic T-cell response to the antigen, drugs, infection, anything, and they are going to attack the dermal epidermal junction, as opposed to Staphylococcus scarlet skin that affect the spinosum and the granulosum. So these ones affect the dermal epidermal junction, and the Nikolsky sign is positive. Just like in SSS, Nikolsky sign is also positive. Pemphigoid vulgaris, Nikolsky sign is also positive. It is only in bullous pemphigoid that the Nikolsky sign is negative. So if it's not quickly treated, high mortality. So you don't forget, Steven Johnson is just talking about these lesions affecting less than 10% of the body surface area. Once it is more than 30%, that is toxic epidermal necrolysis. So you can easily separate the skin. You notice that the skin becomes necrotic. They are sloughing off. Fever, and if it's in between 10 to 30, you call that SGS, TAN, both of them together. So don't forget it affects the mucosa. It doesn't spare the mucosa. And you can see the necrosis is splitting. These blisters everywhere here. So that's TAN. So the ulcers, we are just going to be very straightforward with them. They are very easy to recognize. So the first ulcer is the venous ulcer. Those are the commonest. And they follow chronic venous insufficiency. Anything that can cause chronic venous insufficiency, maybe from valvular incompetency from any cause, DVT, atriovenous fistula, phlebitis, anything, and that's one way shorting of blood from the legs to the heart is no longer there, and the blood is now pulling in the legs, is moving in both directions, and you have a lot of blood pulling in the legs, causing stasis. They can develop venous ulcer because the venous hypertension can push out fluids, cells, inflammatory mediators, which can lead to inflammatory response within that area of the skin, leading to the ulcer. So where do they typically happen with venous ulcer? You see it at the gator area. So the gator area is just the medial distal part of the ankle. That is it. The gator area, the medial distal area of the ankle. So this is the gator area. This is the gator area, very close to the medial malleolus. That is the gator area. That's where they typically happen. We might not need to know the appearance because it's very difficult to remember, but there will be some associated signs in the question. So definitely we are going to get history of the venous stasis, and that stasis is going to cause discoloration of the skin. So they will look erythematous and erythematous, look thickened, like canified like this, that stasis, dermatitis, and there will be opening of new tiny vessels, spider veins, forming the telangiectasia because of the venous pressure and reflux. And also because of the pressure and the reflux, you notice that the veins become large, tortuous, and twisted. So you get history of someone with telangiectasia with varicose vein, and the person has ulcer. That is definitely a venous ulcer. You don't have to we don't have to be a genius. It's straightforward, to know that. It's not highfalutin. Telangiectasia, varicose vein, ulcer, that is venous ulcer. So for the arterial ulcer, it usually follows an individual with peripheral arterial disease. So maybe atherosclerosis occluded the vessel, reducing perfusion to the leg. So the location is usually at the distal part of the foot. So maybe the distal part of the dorsum, the side of the sole. That's where you get the arterial ulcer. They are usually pointed out, but that's not a clincher. You might not remember. But what we should remember for arterial ulcer is that the pain is usually very severe because it's due to ischemia. So there's no blood flow that is sufficient. So the patient is going to have ischemic pain. And of course, because of reduced blood flow, you notice that the hair around the skin is going to be lost. So you get history that the skin is shining on examination. You get history that when they try to palpate for the pulse, it is absent or reduced. All this ankle brachial index, blah blah. When they feel the temperature of the skin, it is cold. When they look at the appearance of the skin, it is pale. All these things are features of arterial insufficiency. That is an arterial ulcer. Neuropathic ulcer, here it will be painless because there's damage to the peripheral nerves, usually from diabetes. So someone that has diabetes, they can have peripheral neuropathy, and the sensory nerves are damaged, the motor nerves are damaged, and the person cannot even feel pain. Steps on nail, not feeling it. Step on stone, not feeling it. All those micro traumas, can lead to disfiguring of the joints. So the patient can have clawed toes, can have charcoal joints. So once you see that, they examine the leg, they see some disfigurement, clawed toes, charcoal joints. This is likely to be a neuropathic ulcer. Where is it located? You see it at the pressure point, like the base, of the toe. Very, very specific. The bony prominences, that's very typical for neuropathic ulcer. And don't forget the disfiguring, the charcoal joint, the clawed toe, the hammer toe, too many disfiguring of that toe. And of course, the pain is absent because they cannot feel pain because of the loss of the sensory modality. And most importantly, the abscesses to be lost because you need all those sensory nerves to coordinate the reflex. So you try to elicit the Achilles reflex. You stroke you try to kind of percuss the Achilles tendon, and you expect plantar flexion. You don't see that because those sensory nerves have gone. So sensory nerve is gone, motor nerve is gone. So you see absent reflexes on examination. You see the toe disfigurement and of course, the ulcer is going to look undermined. So it's going to be deeper than the surrounding tissue. If you don't remember that, it's fine, but definitely the other supporting examination finding will guide us to the answer. So for pressure injury, like pressure sores, the location usually the clincher. So it's usually due to prolonged immobility. So the person is standing in a place for a long time or sitting in a place for a long time. People on wheelchair, people that are bedridden, moribund patients that are in the ICU for a long time, that are not being moved side to side, they can develop this pressure ulcer. So you're trying to see it in the weight bearing region. What are these points from head to toe? In the head, the occiput. You put the head like that, on the bed. That contact can lead to irritation of the skin around that stuff, and even a pressure ischemia, so which can lead to the ulcer. Then another pressure area will be the sacrum in the buttock and the ischial tuberosity that will sit with. Then of course the heel, of the sole, the calcaneus. Very, very important. So once you see that in the question, sacrum, ischium, occiput, that's likely to be a pressure ulcer. I don't think we need to worry ourselves about the staging. So, but we should remember that it can get complicated with soft tissue infection like cellulitis, and it can even spread to the bone and cause osteomyelitis. So, should we take a break? Let's take a break. This is almost 3 hours on the go. So, this is 4:46. We can take like 30 minutes break and come back 5 o'clock. Is that okay?
Yes, that's fine. Thank you.
Hello everyone, are we back? Hello? Hello?
Yeah, we are here.
Dr. Dr. Babawale, we are back.
Okay. So, moving on to the miscellaneous skin disorders. So, the other ones, acanthosis nigricans. So, acanthosis nigricans is just actually with epidermal hyperplasia. So, and what we typically see is hyperpigmented thickening of the skin. So, this is what it looks like. You see this hyperpigmented thickening of the skin, usually within the intratriginous area, like the axilla. That's where you see. So, it's usually due to acanthosis, like thickening of the stratum spinosum. So, from growth factor stimulation. So, it's very common in people that have any condition that can predispose them to insulin resistance or malignancy. So you have the benign form, you have the malignant form. So the benign form is the one that's actually with insulin resistance, maybe from diabetes, from obesity, from Cushing syndrome, or even polycystic ovarian syndrome. Because you remember, polycystic ovarian syndrome is actually with insulin resistance. So obesity, diabetes are shared with it too. So this insulin resistance can lead to increased production of the insulin growth factors, which can act on the skin and stimulate the growth of the stratum spinosum, leading to acanthosis and thickening and hyperpigmentation of the skin at the end of the day. So once you see this, we should think about acanthosis nigricans and, if possible, rule out any cause of insulin resistance or a malignancy, a GI malignancy. So erythema nodosum looks like this, and the question stem is just going to tell us about painful nodular skin lesion that is present within the anterior aspect of the shin. That's where we typically see it. So painful inflammatory lesions of the skin in the anterior shin. So it's due to inflammation of the subcutaneous fat. So it's a panniculitis. So they can ask about the pathophysiology. So it's actually due to inflammation of the subcutaneous fat in that area. So it is a panniculitis. So you typically see it in people with granulomatous lesion like, tuberculosis, sarcoidosis, people with systemic mycosis, particularly histoplasmosis and coccidioidomycosis. Granulomatous lesions like the Mycobacterium leprosy, Mycobacterium tuberculosis, the systemic mycosis, sarcoidosis, and of course, inflammatory bowel disease. Those lesions are highly associated with erythema nodosum. Very, very common. They can ask you to respect to sarcoidosis, they can ask you to respect to IBD, as well as, histoplasmosis or tuberculosis. Very important we remember that. Because once they start talking about painful lesion in the anterior side of the shin, you know that that's the erythema nodosum they are talking about. So, ichthyosis vulgaris. So, this is the other lesion I was talking about with respect to allergic dermatitis. That is related to filaggrin problem. So the filaggrin gene is deficient, so they don't have filaggrin in them. And we remember that we said filaggrin is a protein that helps to form a barrier preventing entry of microbes and environmental allergen, as well as being a support to hold moisture within the skin. So if there's no filaggrin, there's high tendency for moisture or water to escape from the skin. So the skin appears dry, it appears thick, it appears scaly. So, and also this filaggrin also helps in allowing for the keratinocyte desquamation. It allows them to be properly shed. If there's problem with filaggrin, there's problem with keratin shedding. So most of those old keratinocytes are being retained within the skin. So that's part of what impacts the scaly presentation that we see with respect to ichthyosis vulgaris. So there's defective keratinocyte desquamation and dry skin due to filaggrin mutation. And remember that filaggrin is also a problem in atopic dermatitis. So that's why ichthyosis vulgaris and atopic dermatitis can occur similarly. So you typically see these lesions within the extensor surface of the body and the trunks. So we can see this is something that we can easily recollect. So once you see lesions like this, these dry flaky lesions, ichthyosis vulgaris, and we can see that it has a pattern. It's due to the defective desquamation of the keratinocyte. So we should not forget it spears the flexor areas. It's very common in children. Lichen planus. So lichen planus, we are just looking at for the P's of lichen planus. It's only the P's. The fact that it is pyritic, the fact that they are papular, in shape, they are papular lesions, they are polygonal in shape, they are purple in color, and some of them can also be plaques. Everything is P. So it's just like psoriasis. Psoriasis can be papular, psoriasis can be plaque too. Psoriasis can be pyritic, but lichen planus is usually purple in color. Psoriasis is more of erythematous, they are red. But lichen planus is purple, violaceous, they are pyritic, they are polygonal in shape, and they are usually purples and plaque. Once you see that, lichen planus is a very, very strong differential. We can see the lesions, image F. These are you can see this violaceous lesion. These are not erythematous, and you can see that there are plaques. You can see some plaques, polygonal, they look flat, and planar, they look flat, purple, and you get the history that it's very pyritic. So once you see something looking like this, very, very suggestive of lichen planus. So it has some other additional findings like the presence of the Wickham striae, which are like reticular white lines, within areas of chronic lesions, like in the mucosa. You can see it in the mucosa. This Wickham stride are reticular white lines. And of course, on microscopy, you are going to get features of hypergranulosis, thickening of the stratum granulosum. Please, there is no parakeratosis. Hypergranulosis is very specific for lichen planus. Hypergranulosis. And if you check the dermal epidermal junction, you are going to see sawtooth infiltrate of the lymphocytes there. So it's highly associated with hepatitis C. Some people also talk about some drugs, ACE inhibitors, and some diuretics. Hepatitis C, most importantly, is associated with lichen planus. Just like hepatitis C is associated with polyarthritis nodosa, it's also associated with lichen planus. So don't forget the P's, don't forget the Wickham striae, and don't forget the microscopic features of hypergranulosis and sawtooth infiltrate. So pityriasis rosea. So this one is very easy to get. You see the history telling us there's initial lesion, there's an initial brown or red patch in the neck, in the trunk, which is more like a single lesion. So that's what we call the Erhard patch. So you get this single lesion in the neck or in the trunk, which is red or brownish in coloration. Then after some few days, you start noticing some scaly lesions. So scaly erythematous lesion, descending in a form of oblique pattern. So once you get that oblique or Christmas tree like pattern at the back, that is very, very specific for pityriasis rosea. So a single lesion, Erhard patch. Sometimes the patient might not be able to notice this Erhard patch because it's a single lesion, but after some time you start seeing these scaly lesions appearing at the back, in the Christmas tree configuration or pattern. So, and they have scale. They have some scales, to colorized scale. So that is very, very specific for pityriasis rosea. You just need to follow the history. So that's how you are going to paint it, and you make your diagnosis. So for sunburn, is usually caused by exposure to UV light, UVA, UVB. So the most dangerous one there is UVA. So because UVA can penetrate down to the dermis. So UVB most of the time is just the epidermis, and both of them can cause mutation within the DNA of the keratinocyte, leading to death and apoptosis of the keratinocyte. Remember, part of the consequence of mutation, breakage of DNA, will be triggering the apoptotic pathway. So takes out the keratinocytes and you start having some changes within the skin. So the change that is associated with UVB from the word B, sunburn. So you just see erythematous lesion of the skin. Sometimes it can be itchy, but most times you just see red lesions in that skin. So, but UVA causes more damage, more destruction. So UVA can lead to generation of free radicals, which deposit deep down in the skin, destroying the collagen bundles. In fact, when it destroys the collagen fibers, it will allow them to aggregate together and as myofibrils. So it also penetrates down into the dermis, causes atrophy of the dermis and the subcutaneous tissue. And at the end of the day, what we are going to have will be photoaging. So, at very young age, like 35 years, 40 years, due to chronic exposure to sunlight and, penetration by UVA, causing damage to the collagen bundles, the elastic fibers, the dermal tissues, as well as the subcutaneous tissue. That skin is going to be atrophic at the end of the day. So you have atrophic skin with wrinkling, like as if someone is already aging. So that is it. It's due to destruction of, the collagen bundles, the elastic fibers, the subcutaneous tissue. So there's dermal atrophy, there's subcutaneous atrophy, damage to the collagen and the elastic fiber. So watch out for any of them in the offshore. Both of them confer risk of skin cancer. So of course, due to damage of the DNA, so they can trigger skin cancer at the end of the day. So don't forget, UVA is more dangerous compared to UVB that just causes sunburn, erythematous lesion. UVA causes more severe damage. So estimation of body surface area will go follow the rule of 9. So the way we just divide everything, we just divide everything into front and back. So the right arm, front, back, the left arm, front, back, the right leg, front, back, the left leg, front, back, you know, the head, front, back. We now divide the torso into the chest and the abdomen. So the front and the back of the chest 9 each, the front and the back of the abdomen 9 each. So it is only the head and the upper limb that is 4.5. The other ones are 9. So that's the first rule. It is only the head and the upper limb that is 4.5 each. The other ones are 9. So by the time we add everything together, we are going to get a total of 100. I've never seen this in question before, but it's good to know it. So that we can calculate extent of damage by estimating the body surface area that is affected. So if it's only the head, the frontal aspect of the head that is affected now, so that's 4.5%. So if it's both the front aspect of the head and the back of the head, that's 4.5 plus 4.5, that's 9. So if it's only the two legs, front only, that's 18%. So from there we can know the body surface area affected and, you know, calculate fluid you want to give, or even just make a diagnosis. So we want to differentiate between Steven Johnson or toxic epidermal necrolysis. We just look at the body surface area. So this one is affected both the chest and the lower limbs, or the chest and the abdomen, that's 18. Then it's also affecting the back too, you know, up and down, that's 18 plus 18, that's 36. That's already more than 30%. So that's likely to be toxic epidermal necrolysis. So that's the way it works. So classification of burns. So depending on the extent of the burn, we can classify burn into 5 categories. So superficial burn, superficial partial thickness, deep partial thickness, full thickness, and the deeper injury burn. You know, what I just want us to have in mind is that superficial burn is very, very, you know, subtle. The damage is not very, it's just very mild. Involvement of only the epidermis, and what you just see is just a erythematous lesion like sunburn, that is it, and it is due to vasodilation from release of histamine. So that is it. Then we need to remember that partial thickness burn means it has gotten to the dermis, it has affected part of the dermis. For you to say the word partial thickness, that means it has gotten to the dermis and affected part of the dermis. So you can now further classify it into superficial or deep, depending on the extent. Is it, you know, affecting part of the papillary dermis, so that is superficial partial thickness? Is it affecting part of the reticular dermis, so that is a deep partial thickness? One thing that is common to both of them is that both of them they form blisters, as opposed to superficial burn that you see erythema. Here, partial thickness, you form blisters, but there are other things that separate them. For the deep partial thickness, the pain receptors and the vessels are gone. So we can start again. The superficial burn is confined to the epidermis only. We just see erythema, that is all. Superficial partial and deep partial, so both of them they have gotten to the dermis. Now both of them will form blisters, not erythematous lesion, but blisters. That's what we are going to see. But what is going to separate them? Because what is going to separate them is the loss of the pain receptors and the vessels for deep partial thickness. Now, because of the loss of the pain receptors for deep partial thickness, it is not going to be painful. Because of the loss of the blood vessels for deep partial thickness, the lesion is not going to blanch when you apply pressure. So superficial burn, epidermis, erythema, it is painful in terms of sensation. Superficial partial thickness, it has extended to the papillary dermis. It will form blisters, not erythema. The pain sensation is intact because the pain receptors are there, the blood vessels are there, so it will blanch with pressure. and of course sensation, it is painful. Deep partial thickness, because it's a partial thickness bone, you will see blisters. The vessels are good. If you try to blanch on that lesion, it will not blanch because there's no vessel to contain the blood. If you try to apply pain stuff, you want to elicit pain, it will be painless because the pain receptors are taken. So it is only pressure that you can elicit. So the full thickness and the deeper injury bone, they are like the same thing. It's just the only thing that is different is just the extent. Full thickness has taken the entire dermis. The entire dermis is gone. It's not just extending to the reticular. It has taken everything. So epidermis and the dermis are gone in full thickness. While in deeper injury, that's taking the epidermis, dermis, and parts of the facial or the subcutaneous tissue or even the muscle in some situation. Deep injury bone. So the appearance of the full thickness and the deeper injury is just white, charred tissue that looks waxy and inelastic and leathery. So once you see any of this, leathery, white, inelastic, of course it will not blanch. The blood vessels are good. It's either full thickness or deep injury. So you can only identify whichever one is you are talking about by based on what you see. So if you are seeing muscle, that's likely to be a deep injury that's taking the fascia. So you see waxy, leathery, tissue with no pain sensation, only pressure. So if you follow that approach, you'll be able to remember the peculiarities of any one of them. So skin cancer, 3 of them: the basal cell carcinoma, the squamous, and the melanoma. So it's very easy to figure out. Basal cell carcinoma is the commonest one. So I see this basal cell carcinoma as a very benign lesion. This guy is malignant too, but it doesn't behave like a malignant lesion. It rarely metastasizes, and it's very common in the sun exposed area of the body, like the face, the lips. That's where you see basal cell carcinoma. It's the commonest, but it has different types, different appearance. So you can have the nodular type, and what are you going to get in the description? Pearly nodules, and you see blood vessels running over it, telangiectasias. So you can see telangiectasias with road borders. So once you start describing telangiectasia, spider vessels over a nodular lesion, and you're thinking it's a malignancy, you go for basal cell carcinoma. So you see their borders, they are rolled up. So that's the nodular one. You can see some, they are the superficial type. So you just see erythematous patch or plaque with scale. That's the superficial form. And you can also have the infiltrative form that is just infiltrating into the skin, forming ulcer that is non-healing. You might not be able to differentiate between them based on the gross appearance until you do a biopsy. But what you see on gross stuff can still give you an idea. For example, this one looks like, you can see the pear-like, pinkish lesion here, the nodules, with a central ulcer. And of course, you can see like tiny vessels running over it, which are not very prominent. So this is, highly suggestive for basal cell carcinoma. You can see the infiltrative part that is eating deep into the nose. We can see the scaly type, which is superficial type, erythematous lesion with central scaling. So superficial type, this, infiltrative, this, the nodular one, this. And what is going to give it away will be the biopsy finding, in which we are going to see the basaloid cells, because this is tumor that affect the basal cells of the epidermis. That's it. So you are going to see basaloid cells, which is going to show their nuclei, arranged in a peripheral palisading pattern. What that means is that their nuclei is going to be distributed as if they are fencing, as if they are forming a fence, parallel to each other, like parallel to the surface. You can see this one here, here, like that, moving, in a palisading fencing pattern, side by side. You might not be able to identify that on histology, but once they give us that description in the question stem, palisading, once you see the word palisading, basal cell comes to mind. That is not what we are going to look for squamous. Squamous affect the squamous cells, the keratinocytes. Remember, keratinocytes. So, and we are going to see, keratin-like pearls. That's what we are going to see in the description. So once you see keratin-like stuff, squamous cell cancer. So it's the second most common cancer. You're just going to see like a scaly erythematous purple or plaque. Just see this scaling on it. That's very typical for squamous cell carcinoma. This is it. This is under 1 year in the lips, and you can see the histology. These are the keratin-like pearls. So they are going to put it in the history. Histology showing the keratin.
Sorry, Dr. Babola, I really missed out on this squamous cell carcinoma. Well, I have a question. You said the basal,
the what? Hello?
Hello? Yeah,
yes.
Sorry.
Okay.
You said in basal cell carcinoma, the keratinocytes are affected, right?
Yes. So it's like the uncontrolled proliferation of the keratinocytes. So keratinocytes. So that's why on histopathology we are going to see something related to keratin. Keratin pearls. Keratin. We shall see keratin. What's the keratin? Squamous cell.
For the basal cell carcinoma.
So basal cell palisading. You are going to see the word palisading. They will say the cells are distributed in a palisading configuration, side by side. So that's what to watch out for.
So the small cells are affected by the keratinocytes are affected by squamous cell carcinoma.
The what? Hello?
That's I'm saying in squamous cell carcinoma.
Yes.
Hello, can you hear me?
Yes, yes.
Yes, so I'm saying like in squamous cell carcinoma, the keratinocytes are affected.
Mm-hmm. So the keratinocytes are normally proliferating there. So why the cells within the basal layer of the skin, the stratum basale, those are the ones that are undergoing abnormal proliferation for basal cell cancer.
Can you please state the squamous cell stuff again? I didn't get it because my internet was
okay. Okay. So for squamous cell is the second commonest cancer. Part of the risk factor is history of immunosuppression. Can actually predispose sun exposure to some chemicals too, like arsenic. But most of the time you might not be able to pick a risk factor. So you just work with the histology or the presentation. So usually we are going to see the patient having like erythematous nodule, with a central scaly crust, just like this. You can see this image. You can see the background erythematous lesion, with a scaly crusting. You can have this, for squamous cell. But what is going to give you away the clincher, the diagnosis when you do your biopsy, and you see the keratin-like, pearls. So this is what they look like. This wall-like configuration. That's keratin in the tissue. So, and one thing about squamous cell carcinoma is that they can develop from a background ulcer. They can develop from a background scar. So you can have an ulcer that is non-healing. So it can undergo malignant transformation and it can become a form of squamous cell carcinoma. Even a scar, maybe from bone injury, from trauma that's been long for like 20 years, they can transform. And you call that kind of transformation the Marjolin ulcer. So just notice that ulcer is not healing. It can undergo malignant transformation and become a squamous cell. So once an ulcer changes to a squamous cell cancer, we call that Marjolin ulcer. So Marjolin ulcer can also be, ulcers that are chronic, can also transform and develop into squamous cell cancer. So there's also something we call the actinic keratosis. So this is like a dysplastic lesion in the skin that also present like squamous cell cancer. In fact, you might not be able to make your diagnosis until maybe you do your biopsy, but they are pre-malignant lesion that are very common in areas of sun exposure. So you just see like an erythematous lesion with scaling too. Erythematous lesion in the face with scaling, just like squamous cell. And when you do your biopsy, you see dysplastic feature. They have not yet breached the basal membrane to become cancer. So you are just seeing dysplastic feature. And one thing again about it is that it is more felt than seen. So if you do your palpation of that lesion, it's going to feel like sandpaper. So once you see that in the question, sandpaper-like lesion, common in the seen in the face, sun exposed area, the face, you do your biopsy, seeing dysplastic features of the keratinocyte. That is actinic keratosis. That is likely to progress into squamous cell carcinoma if not, quickly treated. So that's that about, the squamous cell carcinoma. Don't forget actinic keratosis. Don't forget pre-malignant lesion. Pre-malignant lesion due to disordered growth of the keratinocyte that are showing dysplastic features. So erythematous scaly lesion, when you feel it, sandpaper-like, and they can, progress to squamous cell cancer. So the melanomas are very easy to identify, very, very easy. Number one, the tumor markers HMB45, no, sorry, not HMB45, S100. So
I thought
I'm sorry,
HMB
HMB, yes, HMB45 is there. Sorry, I was thinking about another thing. HMB45 and S100. So that's a tumor marker for melanoma. So, this one can actually metastasize. It can go to the brain, can go to so many places, But what I just want us to the what?
Sorry, what's the second marker for? The second marker for melanoma?
HMB45. So HMB45.
Okay.
HMB45, S100. The presentation ABCDE. So asymmetry, meaning that if you split the lesion into two, so this is an example, melanoma. So if I split this lesion into two now, I'm not going to get two equal halves. Asymmetry. That's the A. The B is that, in fact, once you see melanoma, you pick it straight. You know. So the B is just talking about the border irregularity. So the borders are not regular. They don't have a regular outline like the melanocytic navy. The borders are irregular. Then the C is talking about the color variegation. So you have different coloring. You have some areas that are already clearing. You have some areas that are red. You have some areas that are dark. So they mean different things. So all those areas that are clearing means the melanocytes there, they're already dying by apoptosis. The ones that are dark means that the melanocytes there, they are proliferating actively. Why the red areas are due to vessel ataxia. You have dilation of the vessels. That's just what is causing that. So we need to also know that. Then the D is talking about the diameter. So the diameter of a melanoma is usually more than 6 millimeters. Not cm, 6 millimeters. Then the E is talking about the evolution. So with time, it changes in shape, changes in color, changes in, the size, so many things. So that's the E. So different types, the superficial spreading, the nodular, lentigo, acral, lentiginous. So we don't really need to worry ourselves, but we need to know the driving mutation, which is BRAF. Very important. We need to know the driving mutation. BRAF is a driving mutation. So we can give BRAF inhibitors because of that, like vemurafenib. So BRAF inhibitors. We can also give some immunotherapies like ipilimumab to treat, all these CTLA4 inhibitors, ipilimumab, so to treat it. So moving on to the pharmacology. So the first drug to talk about is acetaminophen, paracetamol. We need to know that it works by irreversibly inhibiting cyclooxygenase 1 and 2. So, but it typically works in the CNS only. It's being metabolized peripherally. It doesn't work peripherally. So that's the reason why it can only serve as an antipyretic and analgesic. So it has no anti-inflammatory action. it has no anti-inflammatory action. It's only an antipyretic and analgesic. So because we know that when it drops the prostaglandin production in the CNS, there's no way the prostaglandin can increase the hypothalamic set point. So it bring it down. So the body, um, will not want to, increase it, because if you have your prostaglandin being present and you raise the hypothalamic set point, your body will think it's been exposed to a cold situation, so it want to increase its metabolic rate to generate more temperature, to increase the body temperature, the core body temperature. But if you inhibit the prostaglandin and it drops the set point, your body will now think it's now placed in a hot environment, so it wants to cool down metabolism and it will bring down the temperature, through that phenomenon. So that's why it can serve as an antipyretic, then analgesic too, because prostaglandin are mediated through the pain pathway. But don't forget, acetaminophen is not anti-inflammatory. So you might want to be careful, of overdosing acetaminophen, because it can cause hepatic problems, hepatic necrosis, because acetaminophen will be metabolized by the liver cytochrome P450 system, to NAPQ high. And this NAPQ high, just like we have said in pathology, is being metabolized by glutathione. But when it becomes too much, it depletes the glutathione, and the NAPQ high accumulates in the liver and damage the liver. NAPQ high is a free radical, so it can damage the liver and lead to hepatic necrosis and failure. So the treatment for acetaminophen toxicity is N-acetylcysteine that can help it generate more glutathione to neutralize the NAPQ high. So you might want to use acetaminophen in children with varicella infection, chickenpox that have fever, influenza, because as opposed to aspirin to prevent Reye syndrome. Because if you use aspirin in those people, the metabolite of aspirin can affect beta oxidation of the mitochondrion, leading to damage of the mitochondrion in the liver, problem with metabolism, nausea, vomiting, jaundice, encephalopathy, hypoglycemia, all those things about Reye syndrome that we know. So aspirin, what we just need to remember about aspirin is that it irreversibly inhibits cyclooxygenase 1 and 2. The word irreversible is very, very important. So when it irreversibly inhibits, the cyclooxygenase, that means that the activity of cyclooxygenase 1 and 2 is paralyzed, and they will not be able to produce the prostaglandin and thromboxane too. So, and we know that thromboxane is very important in causing clotting of the platelets. So that means that bleeding time is going to drop, it's going to increase. But it doesn't have any effect on the PT and the PPT, because these ones are clotting factor related problem. Aspirin doesn't affect clotting factor, it affects the platelets. So you have to be careful of the PT and the PPT key, they will not be affected. So because of the fact that aspirin irreversibly inhibits cyclooxygenase, the activity of aspirin can only wear out when you produce new platelets. So maybe after 4 days, that's when the activity wears out. So in terms of its clinical use, it can serve as antipyretic like acetaminophen, it can serve as analgesic like acetaminophen, it can serve as an anti-inflammatory, as well as agent antiplatelet. Someone that has myocardial infarction now, you can give aspirin as an antiplatelet to take care of that condition. So we have to pay attention to the side effect of aspirin. Aspirin typically affects the GI and the kidneys. So what does it cause to the GI? It can cause gastric ulceration, because it depletes all those prostaglandin E1, E2 that helps to maintain the gastric mucosal integrity, and there is gastritis and bleeding. It can affect the kidneys, because we know that, number one, aspirin can lead to tubulointerstitial nephritis, and we know how that one is going to present. And also it can be a cause of prerenal AKI when it's used for a long time, because it can reduce the level of the PGE2, the PGI2, which are vasodilatory and improve blood flow to the kidney. So when they are out, you don't have that blood flow to the kidneys again, leading to perennial AKI. So, but in very toxic doses, it can cause some metabolic changes as well.
Sorry, can you say that again? I mean, my something is fluctuating, please.
Okay,
I don't know
so
what's wrong.
sorry about that. So I said it can inhibit the production of PGE2 and PGI2. I know that PGI2 and PGE2, they are vasodilatory, they can increase blood flow. So it means that if they are out, you don't have blood flow to the kidneys anymore. So it can cause perennial AKI. It can also cause intrinsic AKI by causing interstitial nephritis. So many agents can cause interstitial nephritis. The beta lactams, aspirin, sulfur drugs cannot cause interstitial nephritis. I've explained the reason why it causes GI bleeding too. And I said, with respect to the metabolic changes, it can cause respiratory alkalosis in the early stage. So we know that aspirin contains salicylic acid. So that's an acid. So once it's taken in, it can be detected by the peripheral chemoreceptors, as an acidic agent, and they want to bring it out. And the only way you can reduce the acidity is by hyperventilating to bring out CO2. So they try to hyperventilate, leading to respiratory alkalosis. That's the first thing. Then later, because of the fact that aspirin causes uncoupling of oxidative phosphorylation, so it means that the body will not be able to generate ATP through the oxidative phosphorylation pathway due to the uncoupling effect of aspirin. So they'll be forced to tilt towards the anaerobic pathway, which is production of lactic acid, bringing about metabolic acidosis. So with time, you can have a mixed picture of respiratory alkalosis and metabolic acidosis. So how do you treat? So before I go, don't also forget it can cause vestibular neuritis leading to tinnitus. So it can cause tinnitus due to problem with the vestibular nerve, aspirin. So how do we treat? You give sodium bicarbonate. So this is not like you treating it directly. What you are just doing is you are trying to alkalinize the blood as well as the urine, because when you alkalinize it, it is an acid. So when acid reacts with a base, there's going to be ionization, because the acid you want to release its proton to react with this bicarbonate, the HCO3 minus, so that it can react with it to form H2CO3. So that process, you are going to have ionization of the aspirin. And you remember in renal that anything that is ionized is water soluble. They are not lipid soluble, so they cannot cross the membrane of the renal tubules. So they will stay within the renal lumen, they will not be reabsorbed, and they will be excreted. So that's the principle of using sodium bicarbonate to treat toxicity from aspirin. So celecoxib is good. Instead of inhibiting both COX-1 and COX-2 like aspirin, it only inhibits COX-2. So when it inhibits COX-2, it means you cannot generate prostacyclin again, PGI2. And PGI2 is very good to modulate the pain pathway, the inflammatory pathway, as well as like vasodilation, and inhibit platelet aggregation. So PGI2 is there to inhibit platelet aggregation, to modulate inflammation and pain, and also inhibit platelet aggregation. I have to emphasize that. So because of the fact that it can, celecoxib can block PGI2 production and suppress inflammation, it can be useful in treating some inflammatory diseases like rheumatoid arthritis and osteoarthritis. But the bad side will be the effect of celecoxib on inhibiting PGI2 production, particularly with respect to the fact that it prevent when PGI2 is out, it doesn't allow for it prevents platelet aggregation. So let me take it again, don't let me confuse you guys. PGI2 is there to prevent platelet aggregation. So when the PGI2 is out, it means that you have unopposed platelet aggregation, because there's nothing to prevent platelet aggregation again. So platelet will just be aggregating because PGI2 is out, and because our thromboxane, they are intact. Because Celecoxib is only inhibiting COX-2. It's not inhibiting COX-1. And COX-1 is the one that produces thromboxane. So thromboxane will be there, causing unopposed platelet aggregation, leading to thrombosis. So the fear with respect to the use of celecoxib or any selective COX-2 inhibitor is thrombosis. Very, very important. So someone with MI now cannot be giving celecoxib. Yes,
Dr.
I know.
Babola, can you please just summarize it? I became confusing before.
Yes, I know it will become confusing. So let me go back. Celecoxib is a selective COX-2 inhibitor. That is, it reversibly inhibits only COX-2. It doesn't affect COX-1. What is the product of COX-2? Prostacyclin, PGI2. That's the product of COX-2. What is the function of PGI2? PGI2 is to modulate inflammation, vasodilation of the vessel, and also to prevent platelet aggregation. Now, what happens when we use celecoxib? Celecoxib will inhibit COX-2. It will inhibit production of PGI2. There's no PGI2 again. So that means that there's nothing to modulate inflammation. So that means that it can be used to take care of inflammatory disease like rheumatoid arthritis, osteoarthritis. But at the same time, PGI2 normally is there to inhibit platelet aggregation. So it means that if PGI2 production has been opposed, platelet aggregation will happen. Why? Because there's no more PGI2 to prevent that. That's one reason. The other reason is that celecoxib does not affect COX-1. COX-1 produces thromboxane. Thromboxane facilitates platelet aggregation. So it means that you have unopposed platelet aggregation leading to high risk of thrombosis. Do you understand that, Dr. Joy?
Yeah, thank you very much.
So that is why, you want to be careful of using celecoxib in people with heart condition. So
Dr. Babola, COX-1 is not also involved in production of prostaglandins.
Yes, it is. It is.
It's also involved. So COX-2 is it just specific with prostaglandin I2?
Yes. So COX-2 is more for prostaglandin I2. So most of those 2 prostaglandin I2, I'm sure prostaglandin I2. I'm not sure prostaglandin E2, but I'm sure prostaglandin I2. So, but the reason why you are trying to give something that's selective is that you don't want something that will affect, the kidneys and the GI, because by the time you are taking out COX-1, you are inhibiting formation of prostaglandin E1, F1, and the other ones that maintain blood flow to the kidneys and the GI. So once they are out, that means that you are going to have renal AKI, the person can have gastritis. So why not just take care of COX-2 only? But the side effect of that is the risk of thrombosis. So you cannot get a perfect drug. So do you get that, Dr. Antonia?
Yes.
So the other non-steroidal drugs, we have the ibuprofen, the naproxen, the indomethacin, the diclo, and the other ones. So those ones, they work very similar to aspirin, but the only difference is that they reversibly inhibit. They don't do irreversible. Aspirin does irreversible by covalent linking. These ones are reversible. So they all culminate in blocking prostaglandin synthesis, and the three stuff: antipyretic, analgesic, and anti-inflammatory. Aspirin is the one that usually have antiplatelet activity. Aspirin. So that's why when we start talking about cardio condition, we don't usually talk about diclo or napro to prevent to be a prophylaxis for MI or something. They don't work against the platelet. So it's aspirin as antiplatelet activity. So they can work as antipyretic, analgesic, anti-inflammatory, and most commonly you use indomethacin to close the PDA, because PDA gets opened when there is low oxygen or when there is high prostaglandin. So why not block the prostaglandin by giving indomethacin and close the PDA? So you are also scared of the same side effects as aspirin, particularly on the GI and the kidney. What's the kidney? The AKI, the interstitial nephritis, on the GI, the gastric ulceration. So that is it. So very important. So leflunomide. Leflunomide works is one of those immunomodulators. So it works by inhibiting dihydroorotate dehydrogenase. So dihydroorotate dehydrogenase is an enzyme that catalyzes the pathway for pyrimidine synthesis. So it helps to convert dihydroorotate to orotic acid. Then from orotic acid, we now convert it to UMP, which will now take it down to TMP. You remember the pathway. So if you give somebody leflunomide or leflunomide, and there's inhibition of dihydroorotate dehydrogenase, inhibiting formation of orotate, there's no pyrimidine, and pyrimidine is a very essential component of our DNA and RNA. So like uracil now is not being formed, thymine is not being formed, so DNA and RNA will be suppressed, and all those hyperproliferating cells, particularly the T cells and the B, don't mind them, it's both of them, T cell and B cell proliferation is suppressed. So, but the reason why they are talking about T cell proliferation is that if you look at the clinical use, all these inflammatory diseases like rheumatoid arthritis and psoriatic arthritis, what is causing most of the problem is the T cell. So, that is why they are not focusing on the B cell. So the T cell is what is driving that inflammation. So suppress the T cell and then suppress the inflammation. So I just feel we just need to remember the enzyme. We might not need to remember the use. There are so many drugs, there are so many diseases that you can treat with leflunomide. But we should know that it's one of the DMARDs, the disease modifying agent for rheumatoid arthritis. So leflunomide, just like methotrexate, hydroxychloroquine. So biphosphonate, so very important. We need to know biphosphonate, very very important. Biphosphonate, particularly alendronate, talk about this, and restronate, talk about this too. So what did they do? Now they are pyrophosphate analogs, so they can bind to hydroxyapatite in bone. So this is like one of the chemical composition of bone. So they bind to hydroxyapatite in bone, and what they do is that once the osteoclast reach out to the bone, this is going to displace this biphosphonate. So biphosphonate is going to be relieved by the osteoclast, and the biphosphonate will now bind to the osteoclast and inactivate the enzyme that they use to mediate bone reception. That's what happens. So what we are trying to achieve with the use of biphosphonate is to suppress the osteoclastic activity in the long term, so that you want to minimize bone resorption. Now, it means that you are going to limit fracture of the bone, that way. So it's very, very useful for postmenopausal osteoporosis. It's going to increase the mineral density, and it's going to reduce the fracture rate. So you can also use it to treat hypercalcemia, because you know that the more bone resorption, the more release of calcium. So you can suppress that, reducing the calcium level. You can use it to treat Paget disease of bone. We know that Paget disease of bone has the osteolytic phase, so you can suppress that by giving the biphosphonate. Metastatic bone diseases are highly associated with fracture, similar to osteogenesis imperfecta. So you suppress the fracture rate by giving biphosphonate. So osteoporosis, metastatic disease, metastatic bone disease, Paget disease of the bone, osteogenesis imperfecta, biphosphonate is good. In fact, biphosphonate is useful for almost all of those bone disorders. But we need to remember the side effects. So you can test any of these three. Esophagitis, which we know, inflammation of the esophagus, biphosphonate is one of those agents, like tetracycline, iron supplement, KCl. Biphosphonate is one of them. Can cause esophagitis. It has been shown to cause osteonecrosis of the jaw. So, and most importantly, it can cause atypical femoral stress fracture. In fact, this is kind of contradicting. You are giving a drug to prevent fracture in metastatic bone disease, in osteogenesis imperfecta. It's now causing atypical femoral stress fracture. So, looking at the nomenclature, atypical, it means that you are having a stress fracture at a site that is not usual. The commonest site of fracture of the femoral bone is the neck, but people that have a long history of utilization of biphosphonate have atypical fracture of the femur at the shaft, diaphysis. That is it. Atypical. Why is this happening? This is happening because in order to strengthen a bone, you need constant remodeling. As you are forming the bone, you are resorbing it. So the old ones, you are removing them by the osteoclastic activity. But the biphosphonate prevent that remodeling because it has suppressed the osteoclast. So there's no way you want to remove the old bone. So the old bones persist, and at the end of the day, they will fracture. So atypical femoral stress fracture is typical for biphosphonate. Teriparatide is now the rescue. So to prevent this complication, you might want to use teriparatide. So what is teriparatide? Teriparatide is a recombinant PTH analog. And if you remember in endocrine, Dr. Babinde mentioned that when you give recombinant PTH in a pulsatile fraction, you are going to stimulate osteoblastic activity. When you give PTH continuously, that is osteoclast you are stimulating. But if you give it pulsatile, it will stimulate osteoblastic activity and you are going to form new bone. So that means that you don't have the risk of atypical femoral stress fracture, because what you are having here is you are forming new bone to strengthen the bone. So its own activity is different compared to the anti-resorptive therapy such as biphosphonate. Very, very important. So you can also use it to treat osteoporosis. Very, very important. So moving on to the gout medication. So we have two forms of gout: the chronic gout, the acute gout. So most of the time we are going to get acute presentation of gout. So acute flares, sudden pain, swelling in the toe. They did the microscopy, they saw the needle-like crystals. We are dealing with this gout. So what do you do? Because that acute flare, it's more like inflammatory problem. So you need to suppress that inflammatory response. So that is not the time for you to bring down the uric acid. That's not what you are trying to achieve. You need to relieve the inflammation and reduce the pain. So what do you do? You can give three things: NSAIDs, glucocorticoids, or cortisone. So NSAID is usually the first line that they usually use, but the safest is actually glucocorticoid. That's the safest. So NSAID, very, very readily available. Just give it. So they are going to, because they have anti-inflammatory action, they are going to reduce the inflammation. But one thing about NSAID is that if you use NSAID at low dose, they can increase the level of the uric acid. How? They prevent secretion. They prevent tubular secretion. So if low dose NSAID prevent tubular secretion, that means of the uric acid, that means it can accumulate and cause can precipitate gout. So you have to be careful. You use it with caution. The glucocorticoids are good. Intraarticular, perinatal, orally, anyhow. They can suppress the inflammation and reduce the symptom. Then the last one is cortisone. So cortisone can stabilize the tubulin and inhibit microtubule polymerization. So the same thing grisofulvin is doing, the same thing the vinca alkaloids are doing, the same thing the taxanes are doing. Grisofulvin, cortisone, all of grisofulvin, they are binding to tubulin and they are preventing microtubule polymerization. So when the microtubules within the neutrophils cannot polymerize, there's no way the neutrophils can move from place to place. So the chemotactic movement of the neutrophils is stopped. So, and the neutrophils are very, very involved in driving the inflammatory response in gout. So you can suppress the inflammatory response and the person will be alright. But on the long term, what do you want to do? So you want to prevent that chronicity. And what is causing the problem ab initio? The uric acid level. So you want to bring it down so that you don't have any precipitation, any flare. So the person can be safe to take alcohol, can be safe to walk around without expecting any flare, because we have reduced the uric acid level to the barest minimum. So that's when all the uric acid reducing drugs come into play. So which includes allopurinol, probenecid, febuxostat. So we need to pay attention more to allopurinol, febuxostat. So those ones, they usually ask them. So both of them work similarly. Febuxostat and allopurinol, they both inhibit xanthine oxidase. So xanthine oxidase is an enzyme, just like we can see in this picture, that it inhibits conversion of hypoxanthine to xanthine, as well as xanthine to uric acid. So allopurinol and febuxostat both prevent conversion of hypoxanthine to uric acid and brings down the level of uric acid. So you can also use allopurinol in people with tumor lysis syndrome. So like you're expecting lysis of the cell releasing uric acid. So to prevent that conversion to uric acid, you can quickly give allopurinol that will prevent hypoxanthine and xanthine going to uric acid, and can prevent tumor lysis, nephropathy from uric acid accumulating in the blood. So pegloticase is working on uric acid itself. Hello. So pegloticase will convert uric acid to allantoin. So allantoin is a more water soluble form which can be easily excreted. So probenecid works differently. So what probenecid is kind of good, as opposed to low dose NSAID that prevents secretion. Probenecid prevents reabsorption so that it doesn't accumulate. It's not reabsorbed in the proximal tubule, because that's where we reabsorb uric acid. So it's very good to be a uric acid lowering agent. But the problem with probenecid is that when something is not being reabsorbed, there's a high tendency of it staying within the renal tubule, and it can precipitate out, leading to uric acid stone. So it can cause uric acid stone, probenecid. So we have to pay attention to those side effects. So I've talked about the side effect of low dose NSAID. Low dose NSAID prevents secretion, allows uric acid to accumulate. The same thing as diuretic. So thiazide and loop diuretic, both of them can cause hyperuricemia because they prevent secretion of the tubular secretion of uric acid. So that's why you are seeing diuretics and low dose salicylate causing prevention of tubular secretion, elevating uric acid level. Probenecid, the mechanism of action by which it reduces uric acid is to prevent reabsorption, but it can actually precipitate stone because of that. So high dose salicylate and probenecid prevent tubular reabsorption. So it means that if you want to treat acute gout, it might be good for you to give high dose of salicylate so that you prevent the tubular reabsorption and you reduce its level. But high dose salicylate is also associated with some side effects. We know the kidneys, the GI, the hair. So anything missing out? So we also have to remember the fact that we don't combine xanthine oxidase inhibitors with some agent like azathioprine and 6-methyltopurine, because this agent depends on xanthine oxidase for their elimination. So if you have given xanthine oxidase inhibitor, you have inhibited xanthine oxidase, there's nothing to metabolize azathioprine and 6-methyltopurine. The person is joking with myelosuppression. So moving on to the TNF inhibitors. So we have two categories of TNF inhibitors. We have the etanercepts as well as the monoclonal antibodies. So let me start with the monoclonal antibodies. They are very easy and straightforward. Adalimumab and infliximab. So the commonest one that they ask is infliximab. So if you are going to get any question, they might talk about infliximab. So infliximab is a monoclonal antibody that binds to TNF, subdue it, reduce it, and it can suppress so many inflammatory diseases, which I don't encourage us to cram. Maybe if you want to know anything, pay attention to inflammatory bowel disease. TNF plays a very strong role there inflammatory bowel disease, TNF is very, very important there. So by the time you give infliximab, you can use it to take care of IBD. Etanercept is not a monoclonal antibody. So etanercept is actually a decoy receptor. So it's like a receptor for TNF. There are two receptors for TNF in the body. There's a receptor on the white blood cell that activates the white blood cell. There's another one that we call the soluble receptor that inactivates TNF. Whenever TNF binds to a soluble receptor, it becomes inactivated. So etanercept is a form of artificially created soluble receptor for TNF that is coupled to the Fc region of IgG. So the reason for the coupling is to prolong the half-life of this etanercept so that it can stay in blood for a long time. So by the time it's there, TNF will bind to this etanercept and it will be subdued, it will be suppressed and inactivated. So there will not be any TNF to drive any inflammatory disease. But you have to pay attention to the adverse effect of TNF inhibitors, which is what? Risk of granuloma breaking down. Because remember that TNF is very, very important in forming those granuloma. So you want to rule out that this person doesn't have a latent TB. So if there's a TB hiding somewhere and we give TNF inhibitor, breaks down the granuloma, the tuberculosis becomes activated. So it's a very common cause of secondary tuberculosis. Yes, Dr. Antonio.
Sorry, this internal cell function confuses me a lot. So can you please explain that now?
So, this is a principle.
The model.
This is a principle. You have two receptors for TNF in the body. In the body, there are two receptors for TNF in the body. There's a soluble receptor. Whenever TNF binds to the soluble receptor, it will become inactivated. There's another receptor for TNF on the white blood cell. That is the one that activates the white blood cell to drive inflammation. So when TNF binds to the white blood cell receptor, it will activate the white blood cell and it can drive inflammation, causing rheumatoid arthritis, psoriasis, and the likes. So when they are done with their work, they will disembark on the white blood cell, they will bind to the soluble receptors, and there will be reduction in the action. Now you want to maximize the activity of that soluble receptor. So you make majority of the TNF receptor that is available, make it a kind of soluble receptor. What is that soluble receptor that you are now creating? Etanercept. You see, etanercept is a drug, but it is a drug that has a configuration of a receptor. Configuration of a soluble receptor that has been added with Fc portion of IgG. So the Fc portion of the IgG component of that etanercept is going to make it stay long in the blood, so that you have most of the TNF binding to it. And what will happen? Once the TNF binds to that etanercept, that TNF receptor is going to get inactivated, and it will not be able to modulate its activity again. Do you understand? Do you understand now? Hello, Dr. Antonia.
Yes.
So that is the way it works. It is a decoy, like deviating it from the normality. Instead of it binding to the white blood cell, it will bind it to etanercept and it will be inactivated. So the last one is the imiquimab. So imiquimab is a drug.
Well, you didn't finish the adverse effect before the patient.
I didn't finish what?
Talking about the adverse.
Okay, yeah. So
You didn't finish the adverse.
yes, thank you. So they can break down the granuloma, and it can be a common cause of secondary tuberculosis. So they place them on this drug. There's a latent tuberculosis somewhere. The granuloma breaks down. The tuberculosis, Mycobacterium tuberculosis organism escapes. They move to the upper lobe. Cavitary lesions everywhere. Secondary tuberculosis. So, but they can also be a cause of drug-induced lupus. It's not very high yield. When it comes to drug-induced lupus, you want to think more of, procainamide, isoniazid, clopropamide. Those are the common ones. But it's good to also know that the TNF alpha inhibitors can cause drug-induced lupus. So, imiquimab. Imiquimab binds to toll-like receptor 7. These receptors, you find it in the macrophages, in the monocytes, and the dendritic cells. So what they do is that once this imiquimab binds to this toll-like receptor 7, it will activate these macrophages, activate the monocytes, the dendritic cells, and subsequently they are going to activate the other white blood cells like the T cells, true, and the B cells, making them elaborate cytokines. Particularly, I think I have them here: interleukin 6, interferon, and TNF. So these interleukins are going to destroy whatever tissue you are trying to attack, maybe the wat or actinic keratosis. So that's why imiquimab most of the time is very useful in the treatment of HPV warts. Imiquimab is a drug that we use to take care of it. So we should remember that it works by activating toll-like receptor 7, which will at the end of the day activate release of cytokines that will lead to inflammatory response, destroying the lesions, which can be the warts or the actinic keratosis. So with that, we have come to the end of.
What are the cytokines again?
Interleukin 6, TNF alpha, interferon alpha. So those are the cytokines. So we have come to the end of
Sorry. Sorry to just drag us back. If you could go to the beginning of the pharmacology, I just wanted to ask a question if you could throw more light there.
Beginning of pharmacology.
Yes.
Which one?
I wanted to show you something. No, just at the diagram there.
Okay,
Yeah,
okay.
this one. No, the diagram.
Okay.
Yeah.
Okay.
Is there any way to throw light on that NFKB and the inhibitory KB?
Okay. Well, I've never studied this, but NFKB is more like a nuclear factor. So NFKB is there to stimulate the production of almost all the inflammatory mediators, interleukins, the prostaglandin. They can go through this NFKB. So if you give anything that inhibits NFKB, that means you are trying to bring down inflammation. So that's the mechanism of action of glucocorticoid. They suppress NFKB. I think they do that by activating an inhibitory KB. So NFKB is a nuclear factor, kappa, so that drive expression of some transcription factor, which leads to production of inflammatory mediators. It can be anything: interleukins, prostaglandin, cytokines, anything. Now, glucocorticoid inhibits that NFKB. How does it do it? It will activate the inhibitor for the NFKB. So we might skip this step of inhibiting NF. We should just know that the downstream effect is going to be the glucocorticoid inhibiting NFKB. You can see this, minus sign pointing to the NFKB. You can see that. So, but what this arrow is just saying is that glucocorticoid activates inhibitor of NFKB, and in the process, that inhibitor of NFKB inhibits NFKB. Do you get? So, there's nothing to drive the inflammatory process at the end of the day. Because NFKB on its own, if it's left alone, it activates the cyclooxygenase. Do you get it? NFKB ideally activates cyclooxygenase. So that means that when you give glucocorticoid inhibiting NFKB, when you give glucocorticoid activating inhibitor of NFKB, that inhibitor of NFKB will inhibit NFKB. You see, Dr. Joy, don't get confused with this NFKB causing positive arrow. You see, what you are just trying to depict is the normal function of these guys. Now, the normal function of glucocorticoid is to stimulate IKB, inhibitor of KB. The normal function of IKB is to inhibit NFKB. The normal function of NFKB is to activate COX-2. So you be the one to now start tracing everything. When IKB have inhibited NFKB, what do you think will happen to COX-2? COX-2 will be switched off. Do you get that? So don't get confused that because this one is
Yeah.
still showing positive, that no, they're just trying to tell you the normal function of NFKB. That's what they are saying. So
Yeah.
so
So what I was asking the question was, we got a question whereby I wanted to know the function of that inhibitory KB. That's what I was asking mostly. When I saw it, I was thinking you would throw more light on it. That's what I was asking. Thank you.
okay, but can you use that knowledge to answer the question now?
I think, yeah, somewhat I will be able to. I think so. Thank you.
Okay, if you have the question, you can put it on the page so that we can see it. So then I think I missed something out here. Um, I was supposed to mention something about the Samsters triad. So people that use aspirin, you know, can develop this hypersensitivity, particularly when there is asthma and nasal polyps. And the reason is that when you give aspirin will shut down the COX pathway because it inhibits COX-1 and COX-2. And the next thing is that you have majority of the arachidonic acid stuff, you know, diverting towards the lipooxygenase pathway that we have here. So the lipooxygenase, all the arachidonic acid, instead of going to the COX pathway, they will be moving. You know, they will not be going through this COX pathway. They'll be going through the lipooxygenase pathway to form leukotrienes. And leukotrienes are very, very bad inflammatory mediators that can cause bronchoconstriction, you know, bronchospasm and the likes. So which can trigger the reaction like coughing, the chest tightness, the difficulty in breathing, you know, with respect to use of aspirin. Particularly in someone that has like a problem before, which is asthma. So somebody already having asthma, nasal poly, you now give aspirin. So it can exacerbate the bronchoconstriction because of this effect, and you want to avoid it in them. So yeah, so that is that. So do you have any other question before we call it a day?
Yes, sorry. Sorry, because of my network was really bad today. I don't know why. So, and I don't want to take us back. So, I don't know if you can throw more light on melanoma.
On which one?
Melanoma.
Melanoma. I'm coming.
Yeah.
Let me see if I can pick anything from here. The coxib. Okay, they were not really specific. They were not really specific. But COX-2 definitely, you know, is responsible for prostacyclin. Alright. So melanoma. We just talked about the ABCDE. So the A for the asymmetry, the B for the border irregularity. So we said most of those melanomatous lesion, you see them like this, image I. So they follow the ABCDE principle. You see that the border is asymmetrical. If you divide it into two, you cannot have two equal halves. Asymmetry. You look at the border is irregular. You know, irregular border. You know, that's B. The C is the color changes. So you know that some parts have light color, some parts have dark color. You know, that's the color changes. So the dark color areas means you have high proliferation of the melanocyte there. The light color area means that the melanocyte there are already becoming quiescent. You can see some reddish area too sometimes, which talks about vessel dilation. Then the D is talking about the diameter. The diameter of a typical melanoma should be more than 6 millimeter. Then the E is talking about the evolution with time. So you notice that with time, the color changes, the shape changes, the size changes. So any lesion that have some similar property as this, but not complete, you can call that an atypical, you know, nevus. So maybe the color variegation is not there, but the size is more than 6 millimeter. You know, it doesn't follow the stuff of melanoma. So you just call that atypical nevus. So, but our melanocytic nevus, which are the congenital ones, they typically don't follow the ABCD. You know, they are not up to 6 millimeter. They show color uniformity. They have symmetrical shape. You know, their border are well outlined, and they don't show any evolution with time. You know, So that is that.
Is it like lesions, are they like raised or flat? Like in needles? Because in this picture it's a little bit raised, a raised lesion.
No, it's raised actually. These ones that you are seeing, they are just like it has peeled, you know. But this is definitely, this black area are raised. They are raised lesion. But once you see the lesion like this, this melanoma. You can see some that color changes, light color here, dark color there, small lesion like this, in the skin, melanoma. So do you have any other question?
Did you say anything on the types of it? Like
The types.
types
Yeah.
of the
So,
yeah.
well,
Types.
I don't feel the types is very very important like that. So I did not do much research about the types. So,
Okay.
but we just have the four types: superficial spreading. That's the commonest type. The nodular one, just like nodules, the lentigo maligna, and the acral lentiginous. These acral lentiginous, those are the ones that I typically find in the limbs. So, like image L is showing, acral lentiginous. So the one you find in the legs, acral lentiginous. The one that look nodular. Superficial spreading is the commonest. That's the common one that you see. So,
Okay. Thank you so much.
all right.
Thank you so much, Dr. Bob. Yeah, thank you very, very much.
Yeah. So you are all welcome. Um, so we have come to the end of dermatology. So we can just, if we have little time, revise the dermatology once more, just to consolidate all those things that we have talked about. So I wish everybody the best in their, you know, exams. So we are going to close this meeting. Bye bye, everybody.
Thank you. Thank you. But we're still not on our page with questions, so just bamboozle us with questions.
No, Allah. All right.
Thank you so much. Thank you.